So there are lot of newer drugs. I won't be mentioning each and every one. The one which we are expected to know, or the exam point of view, which is important, I will be mentioning. This is not a new drug. We are using it left and right, but I am just starting with this because for your exam there will be questions from this, and I thought it would be better to start with something which you know. Okay, so ceftazidime avibactam, you know what is the rationale or mechanism of action? Plain ceftazidime avibactam, not aztreonam. Avibactam is a bicyclooctane. It's a lactamase, beta lactamase inhibitor. Okay, so it covers which all beta lactamases? I heard some B somewhere. A, C, D. Okay, it won't cover B. It won't cover metallo beta lactamases. It will cover A. It will cover C. It will cover D. Okay, and which organisms it will cover? It is actually recommended for which organism? Klebsiella. It is not, yeah, mainly for Klebsiella. E. coli, not an ideal agent, but for Klebsiella, it is a ideal agent. It won't cover Acinetto. It won't cover Xenotrophomonas. It won't cover. I am mentioning about only ceftazidime. This is about ceftazidime avibactam only, not combination. It won't cover NDM. That is why we are giving aztreonam. So it won't cover Acinetto. It won't cover Xenotrophomonas, and it won't cover anaerobes. So if you are giving ceftazidime avibactam for an intra-abdominal infection, always add an anaerobic coverage in the form of metronidazole. Ceftazidime is a third generation cephalosporin, you know. Avibactam beta lactamase inhibitor, effective against ESBL, AMC, KPC and OXA. Aztreonam won't cover which class? Aztreonam. ESBL. There is no coverage for ESBL coverage for aztreonam. Okay. So basically for 95% efficacy against KPC and OXA, 48 carbapenem resistant Enterobacteriaceae. Pseudomonas also has some coverage, and this group B, metallo-beta-lactamase, indium, it won't cover, and no gram-positive coverage also. Okay. Evidence, recapture trial. Recapture trial, there was a phase 3 randomized control trial. This antibiotic was compared with carbapenem in UTI and pyelonephritis. Microbiological cure was around 70 to 80%. Clinical success was 90%. So that was the evidence for ceftazidime avibactam in urogenital infections. REPROVE trial in hospital acquired VAP and ventilator associated pneumonia. So IDSA recommends ceftazidime avibactam for KPC producing carbapenem resistant Enterobacteriaceae, OXA 48, DTR Pseudomonas, and for if you are using for metallo-beta-lactamase producing organisms, we have to add aztreonam. So regarding dosing, how will you give? If you are combining with aztreonam, how will you give? Simultaneously as 3-hour infusion. Okay. So what is the rationale for adding aztreonam? Aztreonam inhibits NDM so that this thing can cover. Why if your isolate is pure NDM only, okay, why are you adding? Then you can give aztreonam only, right? Yes, because in India or in Asia, rarely NDM exists alone. So there will be something else, maybe OXA or ESBL, some strains will be there along with NDM, coexist with NDM. So in order to combat that, we are combining ceftazidime avibactam with the aztreonam. Aztreonam will take care of the metallo-beta-lactamase, while this avibactam can take care of the other things. Yes, next one is sulbactam durlobactam. What is this? What is this used for? Crab. Is it a beta-lactam beta-lactamase inhibitor? BLBLI? No, this is a BLI. Both are beta-lactamase inhibitors, sulbactam and durlobactam. Okay. So you know that we IDSA recommend sulbactam. This is not available in our country, but in US I think it is available. For us, it is sulbactam only. Okay. So basically, this is recommended. This is the drug of choice for crab, carbapenem resistant Acinetobacter. For other organisms, we don't have data. What is the mechanism of action? What is the mechanism of action of durlobactam and sulbactam? So, it's a beta-lactamase inhibitor. So, actually, durlobactam is like the umbrella. So, it will protect sulbactam from degradation. So, that sulbactam will act on the carbapenemases, and those enzymes which inactivate sulbactam, that will be taken care of by durlobactam. So, it is basically 1 gram plus 1 gram, that is 2 gram, administered every 6th hourly as a 3-hour infusion. Again, this does not inhibit metallo-beta-lactamases. If your Acineto is growing MBL, this won't act. It won't act against MBL producing Acineto. And the sulbactam usually binds to PBP 1 and 3. So, durlobactam will take care of the beta-lactamases, sulbactam will bind to PBP 1 and PBP 3, and that is how it exerts its action. Attack trial, 66% cure rate compared to colistin. Nephrotoxicity compared to colistin is much less. 28-day mortality is much less. And so, what is the current recommendation for crab? IDSA recommendation for treating crab? Okay, the sulbactam durlobactam is a drug of choice, but it is not for us. How will it treat? Combination of high dose sulbactam plus minocycline if sensitive, or tigecycline, or even polymyxin. Minimum dual therapy, and one of the dual therapy should be high dose sulbactam. Okay, and even there are some evidence which shows that if you add a carbapenem along with that, it has some additive effect. Okay, especially imipenem. It has some additive effect because imipenem acts on penicillin binding protein 2. Your sulbactam will act on penicillin binding protein 1 and 3. So that imipenem will directly act on PB22, and already the cover is there, so it won't. That is with the durlobactam, sulbactam and meropenem. So durlobactam will act as the cover. So under the cover, it will degrade the beta-lactamases, and under the durlobactam cover, sulbactam will bind to penicillin binding protein 1 and 3. Imipenem or carbapenem will bind to PBP2. Okay. Another one is the ceftobiprole. It is a 5th generation cephalosporin. It was FDA approved in 2024. Indications HAP, VAP and bloodstream infections covering Pseudomonas and MRSA. So, spectrum, MRSA, Pseudomonas and ESBL. No coverage, carbapenem resistant Enterobacteriaceae and anaerobes, no coverage. Mechanism of action, this is a prodrug, ceftobiprole medocaril. So, it will hydrolyze to the active form and it will target multiple PBPs. Basically, for MRSA it is PBP2A, and for GNB it is PBP1A and 3. So, what will happen when this binds to PBP? Cell wall synthesis will be inhibited. So, it is a broad spectrum bactericidal activity, active against MRSA, multi-drug resistant Streptococcus pneumonia, E. coli, Klebsiella. E. coli, Klebsiella, not carbapenem resistant. Okay, this thing, your community acquired E. coli and Klebsiella, not carbapenem resistant E. coli and Klebsiella. So, not active against CSBL producing organisms, not active against serine beta-lactamases. That is approved indications. So, these are the 3 approved indications for ceftobiprole. One is Staph aureus bloodstream infections, including right-sided endocarditis. So it is an option. It is an alternative for your teicoplanin and vancomycin. Okay, usually the dose is around 667 milligram every 6 hourly. Initial 1 week, 1 to 8 days. Then you can taper it to 8 hourly. Okay, and it is non-inferiority trials have shown non-inferiority to daptomycin. Then another indication is skin and subcutaneous infections. Again 667 for 8 hourly, 5 to 15 days, and community acquired bacterial pneumonia from adults and pediatric patients. So basically ceftazidime 5th generation cephalosporin active against MRSA and your Pseudomonas and non-ESBL, non-carbapenem resistant E. coli Klebsiella. So basically it is for, remember it is for MRSA. That is why it is indication is for Staphylococcus bloodstream infection, skin and subcutaneous, and Streptococcus, multi-drug resistant Streptococcus. So bloodstream Staphylococcus, skin and soft tissue, and community acquired pneumonia. So these are the trials which showed superiority of ceftazidime. Coming to Astronome avibactam. Is it a new drug? Basically, function wise, we know we are using like ceftazidime avibactam plus Astronome, but it is a relatively another drug which will, I think, which will be available in Indian market by end of this year or like you are giving avibactam separately. That is separate. Avibactam plain, Astronome sir. This is one single injection. So it is active against MBL producing enterobacillus because you have avibactam and Astronome. So indication is for pneumonia as well as complicated intra-abdominal infections. But for intra-abdominal infections, remember you will have to add, empirically if you are using it for intra-abdominal infections, always add an enterobic coverage. So mechanism of action is the same as ceftazidime avibactam plus Astronome combination. No enterobic coverage and NDM coverage is there. Okay, this is the same mechanism of action, I am not repeating that. And the pharmacokinetics is a time dependent kill. That is basically for Astronome. So the evidence, Rejuvenate trial, 66% improvement in the clinical cure rate and very minimal nephrotoxicity and very minimal hepatotoxicity. So 2025 IDSA endorses NDM4, endorses Astronome avibactam for NDM and CRE infections. Always remember, requires an anaerobic coverage for complicated intra-abdominal infections. Another evidence is the Assemble trial. Assemble, Resemble trials are there. That also that was used for complicated intra-abdominal infection as well as pneumonia, hospital-acquired pneumonia patients. Those populations were included in the trial, and the 20-day mortality was lower in both groups compared to carbapenem. Now another drug which will, I think, which will soon be launched in India is cefiderocol. What is the peculiarity of cefiderocol? Trojan horse. So what is the mechanism? Yes, it is a catechol side chain which will bind to ferric iron, and bacteria needs this ferric iron for its activity. So what will happen when bacteria engulfs the iron or an iron enters the bacteria? This cefiderocol will tag to the iron, enter into the bacterial, cross the bacterial membrane and into the periplasmic space. So advantage is the normal your porin resistance and all bypassed, because normally when for a drug to enter into the bacteria, it goes through the porin channel. If there is a porin mutation leading to resistance to the drug, doesn't matter, because this drug is not going through the porin channel. It is going through the normal iron pathway. It is going disguised as iron or tagged to iron. it has high affinity for the protein binding protein 3, finally causing bacterial cell lysis. So, and it is also immune to beta lactamases, including A, B, C and D. So, spectrum, carbapenem resistant Acinetobacter coverage is there. Pseudomonas is around 85% susceptible. CRE, including metallo-beta lactamase coverage is there. Stenotrophomonas cover is there. Okay, at a very low MAC. Evidence, Apex NB trial and this European ICU data 2025 reports 70 to 80% success rate with the Pseudomonas infections. Another one is a plasmomycin. This basically, plasmomycin is basically an aminoglycoside. It binds to the 30S ribosome, inhibiting the protein synthesis. So, because of the modifications from the conventional aminoglycoside, this resistance to aminoglycosides are evaded. Okay. Susceptibility, it is used for carbapenem resistant enterobacterial 94% of susceptible versus for CRE, and not active against NDM carbapenemases. So, again this is useful for non-NDM carbapenemases. Dosing, usually we give it as a 15 mg per kg OD dose with the therapeutic drug monitoring, and the target trough is less than 3 mg per ml. Evidence, EPIC trial, compared to meropenem, plasmomycin was non-inferior in complicated UTI. And in carbapenem resistant enterobacteriaceae care study, 81% response in CRE bloodstream infections and pneumonia. Just remember the name and, as I mentioned earlier, name and outcome only. Otherwise, you won't be able to remember everything. So, nephrotoxicity compared to aminoglycosides, it is much less, and that is dependent on the trough level. Okay. Ototoxicity is very much rare. So, these are some of the drugs, and using this chart, you can identify the spectrum or the coverage. If you just go through it, any antibiotic question is asked, you can use this for the coverage part. Will tigecycline be affected by beta lactamase? Tigecycline, not a new drug. Will it be affected by beta lactamases? No. Tigecycline won't be hydrolyzed by any beta lactamase. Okay. Why? Other. Okay. Yes. Antifungal. Very dry. ആകെ അതിനകത്ത് പറയാൻ പറ്റുന്നൊരു പേര് ഇത് മാത്രമേ ഉള്ളൂ, റസഫംഗിൻ. Okay. So, what does this do? This is a beta, echinocandin, right? This is an echinocandin. So, what does echinocandin do? Yeah, it inhibits 1,3 beta D glucan and inhibits beta D glucan synthase enzyme, leading to decreased production of 1,3 beta D glucan. Okay. So, there is a subunit or there is a unit of the beta D glucan enzyme, that is FKS1P. So, this drug will bind to that unit. That is one mechanism of action. Then what will then inhibiting the transfer of the UDP glucose, it will inhibit the enzyme production of beta D glucan, 1,3 beta D glucan. Okay. So, it is similar to Anodilla fungin, but a slight modification. From Anodilla fungin, there is a choline modification at the C5 site of Anodilla fungin. So, that modification will give it longer half-life. nearly 130 hours of half-life. That is why we can use it for once weekly dose. It has coverage against Candida auris only, very minimal MIC only. So it has good coverage against Candida auris, and Candida glabrata is also susceptible. So basically indicated for candidemia, once weekly dosing. Again, this diagram you can use for any newer antifungal which is used. Trials, restore trial compared to caspofungin, nearly 70% success rate. Long term tolerance is around 86%. And in the phase 3 trial, it is being used as for prophylaxis in bone marrow transplant patients, and ECMO stability around 5 times compared to caspofungin. Ibraxa fungups. So again, it is a novel first in the class agent, novel triterpenoid antifungal. So its mechanism of action is distinct from traditional, or its action is distinct from the traditional azoles and echinocandins. So far it is approved for vulvovaginal candidiasis, but for candidemia also it is coming up. Again, it targets FKS1P, our catalytic unit of glucan synthase. It will inhibit 1,3 beta 1,3 D glucan synthase. So finally, it will inhibit with the cell wall synthesis. It will inhibit the cell wall synthesis. It has fungicidal activity. Okay, because of the cell wall destruction, it has fungicidal activity. Similar mechanism to the. So, but compared to echinocandins, the advantage is it has a better or high oral bioavailability. It is not an echinocandin per se. So, and broad activity against Candida auris. Its mechanism of action by cell wall. These are all cell wall synthesis inhibitors. That's all. So, broad activity against Candida auris, and even it has activity against echinocandin resistant candidemia, Candida. So, currently approved for vulvovaginal candidiasis, candidemia coming up. Active against all azole resistant and echinocandin resistant Candida, okay, including auris, and some studies have shown effect against Aspergillus. Trial, Vanish trial. Vanish. Another one, Fosmanogepix. Again, another first in class. It binds to the GPA protein, because there is a when we mentioned the fungal biomarkers, the mannan, anti-mannan, right? So mannan is needed for the cell wall component. So it will bind to the GPA unit of mannan and inhibit the cell wall integrity. Again, it is effective against azole, echinocandin, and amphotericin strains, including Candida auris. That is why everybody is interested in all these novel drugs, because they have activity against Candida auris and echinocandin resistant strains. It also has a good oral bioavailability, so switching from IV to oral will be easy, and has good tissue penetration, including lungs and brain. CARES trial in Candida auris, 89% cure rate. Candidemia also 80% in phase 2 trials, and it has 70% activity against invasive moles also. Another one, Olorofim. I don't know how will you remember the name. Orotomide antifungal. inhibits the fungal dihydroorotate dehydrogenase, DHODH. So it will disrupt the nucleic acid pyrimidine pathway. So this is completely different from our conventional azoles and choline. Fungicidal effect is there. Coverage, again Candida species including Azolla and echinocandin resistant strain, Candida auris. It also covers molds like Aspergillus and other rare molds also. But it does not have activity against mucor. Okay, right. Another one is the N-cochleated amphotericin B. What is the N-cochleation of amphotericin B? It is an oral advantages. This is an oral formulation of amphotericin B. So what you do is there are some lipid structures and you incorporate amphotericin B molecule into the lipid capsule cochleated structure and it will be delivered orally into the site. So advantages, one is oral, and compared to our conventional amphotericin B, the toxicity profile is very much low. So this amphotericin B will be released to the fungus only when these cochleates interact with the target cells. It won't be released elsewhere. That is why it will work at the target site only. No. But as effective as IV. So again some phase 2 trials showing benefit, survival rate benefit. You cannot remember, you needn't write the name of these trials and all because these are all phase 2 trials. The last one, opalconazole. The advantage of this is manufactured for an inhalational route. So it is useful for aspergillosis. So you can give inhalational agent for aspergillosis with the comparable efficacy as voriconazole. So that is, I think this will also come to India sometime in maybe next year or after that. So this is also one which we are looking forward to because Aspergillus nebulized drug, that will be very much effective. So when you get time, these are all the newer drugs with their mechanism of action and indication, just for revision later. Again, another table which show all the coverage of the newer drugs. When you get time, you can just. Thank you. Yes.
I am Dr. Vandana Ji, a colleague of Jacob sir, a consultant clinical hematologist at Caritas Hospital and Institute of Health Sciences. So, sir wanted to discuss about hematological emergencies. So I found out a list, and there are like 17 emergencies. And sir strictly instructed me to keep the talk within 30 minutes. So it became impossible to cover all the 17 ones, but you can just note down like all the 17s are hematological emergencies. So we'll go as a case-based discussion, especially after a post-lunch section. So you have a 14-year-old boy presenting with dyspnea, fatigue, frontal headache, mild confusion, papilledema on fundoscopy. These his vitals, heart rate is 110, saturation is pretty on the lower side, 91, WBC count is 1,35,000, platelet count is 38 and 38,000, hemoglobin is 7.8. They did a chest X-ray while shifting to ICU, that was normal. You wanted to investigate further, so you went ahead with a CT thorax which is showing interstitial infiltrates. What is this case? Any case? With a total count of 1,35,000? It should be leukemia. So this was his peripheral sphere, which is showing myeloid blast. So this is a case of AML. So basically this is a patient with a hyperleukocytosis where he is having a count of more than 1 lakh with the signs of capillary plugging. That is why he is having the headache, papillary edema, confusion, coma, and he is also having hypoxia. So this is because of capillary plugging by the poorly deformable blast with the endothelial adhesion mediated by CD11C and ICAM. So how do you manage this patient? You can do the supportive treatment, strictly avoid fluid overload in this kind of patients, and you have to start him on cytoreduction, especially with the hydroxyurea 50 to 60 milligram per kilogram per day. Along with that, you can do the leukocytophoresis where you remove the WBCs through your spectroptome machine. But this is contraindicated if the patient has a case of acute promyelocytic leukemia, which is called the APL, because it increases the DAC risk. And also starting on tumor lysis syndrome prevention, allopurinol or rasburicase, and you have to monitor the electrolytes, uric acid and creatinine. So for this case, I put the hemoglobin safely at 7.8. What if his hemoglobin is about 6.3? Do you want to transfuse the patient? The problem in hyperleukostasis, when you decide to transfuse a patient, it's a double-edged sword. Already the capillaries are like full. Viscosity, if you're giving PRBC, it increases the viscosity again and it can worsen the leukostasis. So when you can transfuse safely, first, if the patient is having symptomatic anemia, if the hemoglobin is 2, 3, you don't have any other choice, you have to start him on transfusion. Otherwise, if you're thinking like hemoglobin is less than 6 and the patient is having like symptoms of anemia and you think this is due to anemia, then you can transfuse. But preferably, you after reducing the WBCs to a lower level. You can do the leukocytophoresis or you can start him on hydroxyurea and then start him on transfusion. So this is the thing in leukostasis, the blood is already like a sludge. Think twice before adding more cells to the traffic jam. Now next is I think without any the classical history should give you the diagnosis. 34-year-old woman with headache, confusion and bruising. Diffuse headache is diffuse worsened over the last 2 days. Confusion, she is disoriented. Difficulty following commands. Bruising, severe purplish not palpable patches on arms and legs. Any takers? Should be TPTP. Yeah. So clinical examination, she is confused. Neurologically, she is maintaining a GCS of 12. Abdominal, just a right upper quadrant tenderness. CVS, everything is okay. So hematological wise, hemoglobin is 8.2. Platelet is 14,000. LDH is 1,100. Indirect bilirubin is 3.1. Haptoglobin is undetectable. Reticulocyte count is 6.2. What is the next test to do? Bone marrow. Okay. So what does it show? What are you suspecting here? What is the clinical picture suggestive of? Hemolysis. So patient presenting with hemolysis, one test you should do DCT. That is the first next step. Coombs test should be negative. So Coombs test is negative and PT APTT normal. So we wrote out the DAC. Creatinine is 1.8, mild renal impairment. WBC count anyway, it was not mentioned initially, so it was normal. So it is showing, what is it showing? These are the helmet-shaped cells or the broken RBCs. So the diagnosis is TTP. So before jumping into TTP, what score you should do? So we did the plasmic score. It is coming as 7, correct? Yeah. So 0 to 4, low probability, 5, intermediate probability, more than 6, it gives you high probability of a severe ADAM TS13 deficiency. So plasmic score has a high sensitivity, but it is non-specific. So you should have a, like before interpreting the score, you should have a basic clinical judgment. Otherwise, if you randomly start applicating the score to everything, you will get a positive plasma score most of the cases. So this is the pathophysiology of the TTP. You have von Willebrand multimers with ADAM TS13. This will be cleaved to small von Willebrand multimers. But what happens when there is no Adams TS13? The circulating ultra large von Willebrand multimers will produce microthrombi within the vessels, producing tissue ischemia, microthrombus, schistocytes. So classic pendant of thrombotic thrombocytopenia, it was what we used to define the disease, but nowadays what happens is like we should not wait for all the symptoms to develop, and less than 10% of the patients of modern TTP cases are diagnosed with all these 5 symptoms. So pendant is history, we should have high clinical suspicion, so early suspicion is our best weapon. So timing of testing, blood for ADAM TS13 activity should be sent, but it should be done before plasma exchange. So interpretation less than 10% strongly supports the diagnosis of a TTP, and more than 60 is TTP is unlikely. So in immune TTP, it is not just what is missing, it's what's attacking. We should have to find out why there is low ADAM TS activity. So we can do the testing by identifying the ADAM TS13 antibody titer, or we can do something like a mixing study. We mix the patient plasma with the normal plasma and then check the ADAM TS activity again. So there is an inhibitor present, the activity will be still lower, just like we will do in prolonged PT-APTT. So then when the no inhibitor is detected, the other possible reasons include the titer is too low for detection. Somebody might have given some plasma or done some plasma exchange and then send the test, or non-neutralizing antibodies, or prior transfusion. Patient has hereditary TTP. That is also possible, especially in young females during the pregnancy, first time TTP. We should not think of immune TTP alone. So it's a clinical diagnosis, act first, confirm later. So if plasmic score is intermediate or high, begin treatment immediately, initiate without delay therapeutic plasma exchange, glucocorticoids, do not wait for ADAM TS13 levels. So this is a drug which we use in immune TTP, caplazizumab. This is an anti-von Willebrand factor nanobody. It blocks the platelet binding, so it halts the microvascular thrombosis. It is used in severe TTP, neurological symptoms, cardiac involvement, high troponin, poor early response to therapeutic plasma exchange. It can be used in stable cases, but avoid if the patient is having high bleeding risk, because it is blocking the von Willebrand factor. So dosing is 10 mg IV before TPE, 10 mg sub-Q after TPE, then daily into 30 days. Stop when the ADAM TS13 levels are more than 20 to 30%. It gives faster platelet recovery, fewer relapses, and short ICU stay. So plasma infusion, it is not a substitute, but if you are transferring the patient from a center where you don't have plasma exchange to another center, you can definitely start the patient on plasma infusion. Then in hereditary TTP, if the antibodies are negative, always think of hereditary TTP. So they need a lifelong treatment, lifelong management with special attention during the neonatal period and pregnancy. So the prompt treatment involves, we have ADAM TS13 factor recombinant. If it is available, we can give that. Otherwise, it is a regular interval based plasma infusion. Now third case, 36-year-old male, high grade fever for 2 weeks, fatigue, weight loss, gum bleeding, petechia, altered sensorium, recent upper respiratory viral infection. He is febrile, heart rate is 110, BP is borderline, pallor, icterus, petechia present, hepatosplenomegaly present, drowsy. Yeah, it's again. HB is 7.4, WBC is 1900, platelet is 29,000, ferritin is 31,300. That gives you the diagnosis, that is HLS. Triglycerides again high, fibrinogen is 110, LDH is markedly elevated, AST/ALT elevated. So viral BBV positive, bone marrow, hemophagocytosis. So it is like classical HLH case. So what happens in HLS? Basically, you have your immune system which is going wrong. So we are not able to switch off the immune activation. So the defective NK cells and this CD8 positive CD8 T cells, they can't kill the activated macrophages. So it results in a cytokine storm. It results in tissue injury, multi-organ failure. The basic culprits are macrophages. They are hyperactivated. They engulf the cells. Cytotoxic T cells and NK cells impaired cytolytic granule function, and CD4 cells drive the Th1 based inflammation. Then cytokine interferon gamma is the ringleader. So other than that, our fever causing things include IL-6, 10, 18, TNF alpha, soluble CD25, CXCL5, 9, all causes fever, cytopenias, liver injury and shock. And there are genetic triggers, especially in young kids and young adults. So we should think of hereditary HLH also in perforin pathway gene defects. So immune paralysis, these patients will have immune paralysis, their inflammation will be genetically tuned to have an uncontrolled inflammation. So signature finding is hemophagocytosis, may not be present in all cases. So management includes HLH 94 protocol or dexamethasone, etoposide, supportive care, and indications for some cases we have to do the stem cell transplant, which includes so in patients with a high relapse risk or poor prognosis, biallelic homozygous or compound heterozygous mutation in SLS associated gene, and if they are failing to respond to our first primary HLS therapy, central nervous system involvement usually results in recurrent relapses and poor response to the treatment, so they all might require a stem cell transplant. HLH associated with the hematological malignancy, basically based on the hematological malignancy indication. Sometimes they recover without much further complication. In that cases they don't need, but in other cases definitely they will need a stem cell transplant. So next case, 32-year-old female, postpartum, presented 6 hours after delivering a stillborn fetus at term, history of prolonged labor, profuse vaginal bleeding, breathlessness, altered sensorium. BP is 80/40, heart rate is 124, temperature is 38.9, pallor, petechia, bleeding from IV sites. Investigation, HB is 7.2, platelet 38,000, PT 24, APTT 48, fibrinogen is 90, D-dimer is more than 5,000, and peripheral smear showing schistocytes. What's the diagnosis? So it's a disseminated intravascular coagulation. It is a systemic process involving widespread activation of coagulation and fibrinolysis. It can present as an acutely life-threatening or chronically cases triggered by underlying conditions. It is characterized by microvascular thrombi, consumption of platelet and clotting factors, secondary bleeding and organ dysfunction. So this is the pathogenesis of DIC. So you have an underlying condition which is causing activation of intravascular coagulation. So there is one spectrum causing bleeding. So you have fibrin deposition which is causing platelet consumption. So the platelets will be low, coagulation factors will be consumed. So your PT, APTT will rise, and it is produced, and because of all the fibrin deposition, fibrinolysis will start, which increases the D-dimer and impaired coagulation leading to bleeding. Same time, neutrophil activation and endothelial activation can result in neutrophil extracellular traps, increased DNA histone complex, increased double-stranded DNA. So this all can produce microvascular thrombus. So simultaneously, DIC can produce organ ischemia or organ failure. So there is an ISTH, International Society for Thrombosis and Hemostasis, scoring system for DIC. So that should be done in all cases. So how to interpret the score? So basically the score has platelet, INR, D-dimer and fibrinogen. Score more than or equal to 5, initiate management for overt DIC. Score to 5, monitor closely for progression, repeat testing advised in high risk patient. It is especially useful in sepsis related coagulopathy, obstructive DIC and malignancy associated DIC. Why do we need a score? Because even with the clinical history we all knew it is DIC. Why do we need a score? Because it is standardized. We will give an objective evaluation for DIC, and it is developed by ISTS scientific subcommittee on DIC. It combines clinical context as well as lab abnormalities. It can allow us for an early identification. It helps in serial monitoring and prompt intervention. So management overview, basically it is not the primary disease, it is caused or triggered by something else. We have to treat the underlying cause. So if it's a sepsis, malignancy, obstructive DIC, trauma, whatever it is, we have to correct the inciting event. Next is active bleeding management. It should be started if the patient is having overt bleeding or planned for or recent invasive procedures or high bleeding risk, especially post-op patient. So what to transfuse and when to transfuse? So if the patient is having a platelet count of less than 50,000, they are planned for a invasive procedure of the patient is bleeding, we have to give platelet. Otherwise, if the platelet is less than 10,000, we can give platelet. Or if the patient is having coagulopathy with the bleeding, we can give FFP, especially prolonged PT, APTT, hypofibrinogenemia. If the fibrinogen is less than 100, we can give cryoprecipitate. If the patient is having PT, APTT prolongation, this is usually FFP. Along with that, if the fibrinogen is also low, we have to give cryoprecipitate. So thrombosis risk in DAC is definitely there, but anticoagulation concentration used only in selected cases of severe thrombotic DAC, like digital ischemia or something is there. In that cases alone, we can use. Routine anticoagulation is not recommended in DAC. Now, prophylactic anticoagulation not recommended. So, if the patient is having a venous thromboembolism, just like our normal venous thromboembolism patient, we have to treat them. Therapies to avoid: antithrombin supplementation, recombinant thrombomodeling, antifibrinolytics like the tranexamic acid, prothrombin complex concentrate. All these things are usually avoided in DAC, should not be given in DAC. So, next is a 22-year-old male, newly diagnosed precursor B acute lymphoblastic leukemia, 48 hours post initiation of injection chemotherapy, presented with nausea, vomiting, decreased urine output, muscle cramps, tingling, confusion, and restless. What's the diagnosis? Simple. So BP is 160, all those things, okay, fine. So serum potassium is high, hyperkalemia is there, hypophosphatemia is there, hypocalcemia is there, hyperuricemia is there, acute kidney injury is there, LDH is more than 1000. So they can result in cardiac arrhythmias and acute kidney injury. So it is a medical emergency. So it is usually a threatening complication of cancer treatment. Sometimes the patient presenting with acute leukemia and all, they can be in TLS even when the diagnosis need not be due to a treatment. So potassium release, hyperkalemia will be there, that leads to cardiac arrhythmia. Phosphate release, calcium phosphate deposition in the renal tubules can produce acute kidney injury, precipitation in cardiac tissues, arrhythmias, nucleic acid release causing uric acid, hyperuricemia, precipitation in renal tubules, renal vasoconstriction, impaired autoregulation, decreased renal blood flow, renal inflammation, and all these leads to acute kidney injury. So what is it? The criteria is Cairo Bishop definition for TLS. So we have laboratory TLS and clinical TLS. Laboratory TLS more than equal to 2 of the following within 3 days or before or 7 days after chemotherapy. Uric acid more than 7, potassium more than 6, phosphate more than more than or equal to 4.5, calcium less than 7 less than or equal to 7 milligram per deciliter. Clinical TLS, along with this, patient is having creatinine more than 1.5 times the upper limit of normal, cardiac arrhythmias or sudden death or seizure. So we have the risk stratification. First is tumor related factors. Some tumors are prone for TLS like Burkitt lymphoma, ALL, and tumor burden. If the patient is having a very bulky disease, in that case is very high LDH, so that shows highly proliferating tumor. In that cases we have high risk for TLS. And patient related factor, somebody who is having a pre-existing renal dysfunction, elevated baseline uric acid, pre-existing electrolyte abnormalities, all these patients will have high risk for developing TLS. Purpose of risk stratification: assess TLS risk category, we can put it as low, intermediate or high. It can guide the prophylactic measures, like for whom to start hydration alone, to whom to start ilopurinol, for whom we need raspuric acid, and determine the monitoring and the intervention intensity. So we'll do the laboratory test, we'll estimate the tumor lysis. One abnormal test result, we estimate the tumor lysis. Small tumor burden, minimal risk, no prophylaxis. Medium tumor burden, high risk for lysis, we have to give hydration, raspuric acid, cardiac monitoring, 6 to 8 hours of lab monitoring. Medium or uncertain risk for lysis, based on the patient condition. Abnormalities are present, we'll put it as intermediate risk, lab test every 8 to 12 hours, hydration. Allopurinol, basically raspuric acid you can give. Then patient condition, no abnormality, low risk. Large tumor burden, high risk for lysis, hydration, raspuric acid, cardiac monitoring, lab test every 6 to 8 hours. Any case of clinical TLS, hydration, raspuric acid, 4 to 6 hours we have to do the lab test. So general principle that we have to prevent the complication and mortality related to TLS. Intravenous hydration, hypouricemic agent, risk-based approach, intermediate risk hydration plus allopurinol, high risk hydration plus raspuric acid. So raspuric acid, the advantages include it can rapidly bring down the serum uric acid level, greater prevention of laboratory TLS, particularly useful in high treatment uric acid, Burkitt lymphoma, renal dysfunction, but it is not statistically significant reduction in clinical TLS, but it is contraindicated in GCSPD deficiency. So we have to test the GCSPD deficiency, and somebody who had a allergic tendency to raspuric acid also should be avoided giving raspuric acid. So high risk, every 4 to 6 hours is the monitoring. Intermediate risk, it can be 6 to 8 hours. So practical monitoring recommendation for during 72 hours after the therapy is starting, we have to check the labs every 4 to 6 hours. That's the thing. Track morning urine output, watch for signs of electrolyte shifts, cardiac instability, or AKA. If some abnormality is there, we can escalate the care. So management will be same. Begin IV hydration, electrolyte correction, monitor urine output, consult nephrology early if the AKA or risk for dialysis is high. TLS may also occur spontaneously, especially in acute leukemias and high-grade lymphomas. So all these are like management of abnormalities. Potassium, phosphate, and calcium. All the electrolytes should be corrected. Indication for dialysis in TLS. It is required in oliguria, anuria, intractable hyperkalemia, acidosis, and fluid overload, persistent hyperphosphatemia, or uric acid nephropathy. Hemodialysis, uric acid clearance is around 70 to 100 ml per minute. Phosphate removal up to 7 gram per day. It reduces uric acid 50% per 6-hour session. So CRRT is tolerated in unstable patient. So prognosis and long-term renal benefit, early dialysis with plus raspuricase, it gives the excellent recovery rates. So residual renal impairment may persist, that can lead to CKD. And avoid any nephrotoxic agent, especially antibiotics and other chemotherapy when the patient is having TLS-induced renal injury. And I think that's it. Any doubts? PCC should not be, because all this thing can again promote the thrombotic risk. Cryo we can give when the fibrinogen is low, otherwise you should not give. You should see the fibrinogen and then decide on giving cryo. FFP if the PT epithet is prolonged. PCC no. PCC, recombinant factor 7, all those things are not given.
PCC for one of our favorites tells you that the label indication is only for overdose on this. Rest is all unlabeled indications, and if you go through, you'll be scared to use it out of that because the chance of more thrombosis is high. One thing that I would like you to remember is in your TLS, you will have a hyperphosphatemia. So whenever the phosphate goes up, your calcium goes down. So if you have increased phosphate production, chance of hypocalcemia and hypercalcemic seizures are going to be higher risk. So a calcium phosphate score has been a product of calcium phosphate more than 60. So better take patients on early dialysis. Hydration might not be a good option. There's a calcium phosphate product of 60. 60 for a K, and even 50 you have to be cautious. Something. Hydration. So how much ml per hour? 1 to 1.5 ml per kg per minute.
1.4 to, it's actually 3.5 liters per meter square is the hyperhydration target. 3.5 liters per meter square. It's a hyperhydration target. But then based on the renal output, we have to reduce it or increase it. Usually it is 3.5 liters per meter square. That is a hyperhydration target in leukemia.
If you're suspecting it, most of the time, nowadays most of the time, if you're suspecting it, start straight away your vasculitis. So incidence of ALS has come down significantly. Any questions? Thank you, Dr. Vandana. It's a beautiful job. Thank you so much for doing it. Token of appreciation.
Thank you, sir.
Thank you, Dr. Jacob, for inviting me here. So we'll deal with rheumatological emergencies that you might encounter in ICU. So first of all, rheumatology is supposed to be a very cool specialty. Like you don't see much emergencies. It's actually a 9 to 5 job, but sometimes it depends where you work. If you're working in tertiary care BC centers, you do get some calls at the night. And so I've selected some cases which has basically wakened me up from a good sleep. So when do you see these patients actually? So first instance is One scenario is the patient already has a rheumatological disease. You know this patient has a particular label, diagnostic label, and then the patient might come to you with a flare of the rheumatological diseases. They might come to you with a complication of the disease, and they can come with infections, life-threatening infections, because these patients are immunocompromised. Okay, and they can also come with adverse drug reactions to the drugs that you are giving. Next scenario is the patient, we don't know what the patient has. The patient has not been diagnosed with a rheumatological disease. So he might come with a very severe flare of the disease, could be articular flare, a severe dyspnea which prompts to use NIV or ventilator support, rapidly progressive renal failure, acute vascular events, neurological emergencies, acute abdomen, hematological emergencies, and life-threatening infections. So this basically encompasses all the various spectrum, and as you can see from the slide, since this is a very specialty which involves the cooperation of many specialties, a multidisciplinary specialty, so you might have patients coming with any of these symptoms. Okay, so we'll see the first case. So this is basically a 34-year-old lady. She already has a diagnosis of SLE or lupus. So at the time, initially she had arthritis, cytopenia, mucocutaneous involvement in the form of oral ulcers and rash, and she was basically lost to follow-up, as happens with most of our patients. And this time she has come with fever, cough, and dyspnea. She also has hemoptysis. Okay, so the dyspnea is so severe, she's hypoxemic, and she required an NIV, and later she was put on ventilator. So if you look at the investigations, there is cytopenia, okay, there is leukopenia and anemia, significant anemia. So we do anti-dsDNA ELISA to look at the disease activity, which is high here, and the complement levels are low. Both C3 and C4 are low, pointing to a active disease state. Okay, and the X-ray basically showed bilateral interstitial infiltrates, and you can see the CT here. The CT basically shows, you can see bilateral perihilar ground glass opacities with sparing of the periphery. So this is looking like a diffuse alveolar hemorrhage. So this is diffuse alveolar hemorrhage, and the factor which basically clinches your diagnosis is the overall condition of the patient. The patient is having a lupus flare, serologically also. So this supports a diagnosis of a diffuse alveolar hemorrhage. Now DH usually occurs when the disease as such is very severe and active. It occurs in only less than 2% of patients with SLE. So presence with acute onset or subacute onset of dyspnea with hemoptysis and new infiltrates in the chest X-ray, and it is not always associated with hemoptysis. So you might get a hemoglobin fall when there is active hemoptysis, but sometimes these patients may not have a history of hemoptysis at all. So that is where the diagnosis becomes a little tricky. So bronchoscopy with BAL is basically very useful. It can rule out infections, and it can also confirm the diagnosis. So when you see blood in the airway which is not clearing with repeated lavage, that makes you think of DH, and if you take it to the pathologist, they will be able to find out hemocytin-related macrophages. So that is about DH, and DH usually occurs in the setting of an active lupus, clinically as well as serologically, and lupus nephritis is the most common association of DH. So when you see a patient of SLE with DH, always look at the urine sample for active sediments. So rarely you can have DH as an initial manifestation of SLE, which is very difficult to diagnose because it's an initial manifestation. We don't usually suspect lupus in those patients. So mortality rate, even with all the aggressive approach, the mortality rate is high, and it continues to be around 50%. Now, rheumatological cases with DH is not just limited to SLE. You can have it in ANCA-associated vasculitis, Goodpasture syndrome, and antiphospholipid syndrome. So how do you treat these patients? So in all life-threatening emergencies, we bank upon methylprednisolone pulse therapy. So we give 500,000 milligram for 3 days, followed by 1 milligram per kilogram steroids. And other treatment options include cyclophosphamide, rituximab. Rituximab is especially preferred when you have cryoglobulinemic DH or patients with ANCA-associated vasculitis with relapse. Now, what are the indications for PLEX? So PLEX is basically used when patients have anti-GBM associated DH, or then when they have severe DH associated with ANCA vasculitis. So you have to have multiple sessions of plasma exchange in these patients. So that's about DH. So another conundrum that we face often is when a patient with rheumatological disease comes to you with a very life-threatening feature, you are confused whether it's a sepsis or it's just a disease exacerbation. Okay, so some of the factors which tells you that this is a disease exacerbation or a disease flare is that, especially in patients with lupus, is that when there is no high grade fever. The lupus related fever is usually a low grade intolerant fever, and they might have prolonged fever, and when the symptoms are very similar to the initial flare of the disease. So you know a patient has got a particular phenotype at the presentation. So when the phenotype mimics at the time of the flare, so then you are most probably dealing with a disease flare. And when the patient has disease activity elsewhere, that also supports that the disease is active. Okay. So when you have thrombocytopenia without coagulopathy, thrombocytosis, lymphopenia, neutrophilia, very low complements, again points to a lupus disease activity. Absence of toxic granules, again suggestive of a disease activity, and low procalcitonin levels, normal CRP. So CRP is usually normal in lupus. It is elevated. Once it is elevated, you think of an infection. And when you have a rising antibody titer, that also suggests a disease activity more than sepsis. So what are conditions where you get a high CRP? When you are dealing with infections, you will get very high CRP, and modest elevation of CRP in SLE is seen in patients who have arthritis or serositis, or even in some conditions like macrophage activation syndrome also you can have high levels of CRP. So high grade fever, think of macrophage activation syndrome in lupus, but almost always rule out infection, and sometimes it could be drug induced also. What about the acute phase reactant? So we know ESR and CRP are day-to-day, very useful tests in the day-to-day practice. So a ratio of ESR by CRP more than 15 is more suggestive of a flare in SLE, disease activity, or a flare in SLE. Whereas if the ratio is less than 2, it almost always point out to an infection. So we have two very commonly available, very cheap investigations which can differentiate between a flare and a disease activity. And procalcitonin, so this is a very useful test in sepsis, but it could be elevated in diseases like GPA or a Kawasaki disease or a macrophage activation syndrome. You might get some modest elevations in procalcitonin. So it's not a very strict or a very robust way to differentiate, but it all comes with day-to-day seeing patients and experience. It's basically a art more than science when it comes to differentiating a disease flare versus sepsis. So you should also know that neutrophilia, when you see a patient's report, might not always be infection. It could be glucocorticoid induced. So coming to the next case, this is a 38-year-old male with high-grade fever, polyarthralgia, splenomegaly. He also have neutrophilic leukocytosis, very high inflammatory markers. Ferritin is also very high. The infective workup is negative. Okay, your autoantibodies are also negative. So what are we dealing with? You have ruled out everything else. So this could be a Still's disease. Very good. So Still's or adult onset Still's disease. So he was initially treated with glucocorticoids and methotrexate, and he responded beautifully. Then he comes 3 months later. So this time there's a change in the fever. The fever has become very persistent. Okay, he's got persistent fever. The rash has also become very persistent, and the cytopenia, the cytosis which he had, has now gone to cytopenia mode. Okay. So there is a hepatosplenomegaly, the ferritin is very high, and you have low fibrinogen. So what are we dealing with? Macrophage activation syndrome, because we already have a rheumatological disease. So we will call this macrophage activation syndrome or a secondary HLH. Okay. So this patient had adult onset cell disease complicated by macrophage activation syndrome now. So this patient was basically treated with high dose glucocorticoids, pulse therapy, and IVIG. So what is MAS? I think Dr. Vandana has already touched upon this. So it could be primary as well as primary or secondary HLH. Primary is usually seen with genetic defects. Secondary is usually secondary to a hematological malignancy, could be secondary to infection or a rheumatological disease. Okay. So we know the pathogenesis has already been touched upon, so I am not going into that. And the clinical features, all of you know, you have non-remitting fever, cytopenias, coagulopathy, organ dysfunction. It can involve almost all organs in the body, and histopathologically you might be able to get hemophagocytosis in the bone marrow, and you can also stain for CD163, which is usually available in research settings. You will get increased CD163 staining in the bone marrow. So cause and triggers, we know it could be infections, could be hematological disease, or it could be primary. Among the rheumatological disease, this is most commonly seen with systemic onset juvenile idiopathic arthritis, could be seen in around 10 to 40% of patients. Then you can have it in SLE to the tune of 0.9 to 4.6%, and when it comes to infectious triggers, the EBV-induced macrophage activation syndrome is very difficult to treat. It has got a poor prognosis. So this is a diagnostic 2004 HLH criteria. You can get a molecular defect, especially in patients with a primary HLH, and you need to have 5 out of the 8 criteria in HLH 2004 to make a diagnosis of HLH. So coming to the treatment protocol, in connective tissue disease associated macrophage activation syndrome, we usually go for high dose methylprednisolone, plus we can combine IVIG. Okay, IVIG is a good option. And second line options in patients who are refractory or patients have organ dysfunction, we can go for drugs like cyclosporin, or you can even go for anakinra, which is the interleukin 1 inhibitor. Unfortunately, IL-1 inhibitor is not available in India. You can import it on a case-to-case basis, but it's very costly. And for refractory cases, we go back to the HLH 2004 regime, where we combine etoposide with dexamethasone 10 mg per meter square IV, and we also use cyclosporin at 2 to 7 mg per kilogram per day. Now, etoposide is basically a very toxic agent, and for these cases, we usually seek the help of the hematologist as well. So, coming to the next rheumatological emergency, which is catastrophic APS. So, these patients usually have a diagnosis of APS or presence of an antiphospholipid antibody, plus they have 3 or more organ manifestations of thrombosis, and you can have biopsy evidence, and you should exclude some other causes, which I will be showing the subsequent slides. So, differential diagnoses include heparin-induced thrombocytopenia, DIC, TMA, scleroderma, renal crisis. So, the most commonly involved organ involves is the kidneys, followed by lung and the CNS. So, you can see it basically can involve any organ in the human body. Now, what are the differential diagnoses? It could be, the differential diagnosis is important because the treatment also varies. So, you can have scleroderma, renal crisis, heparin-induced thrombocytopenia, DIC, and there are very subtle differences. For example, if you look at the pulmonary involvement, it is more commonly seen with CAPS and less commonly seen with other mimickers. And if you look at the antiphospholipid antibodies, they are usually positive in CAPS, whereas ADAMTS13 levels is useful to diagnose TTP, and schistocytes are usually seen with more seen with TTP compared to CAPS. So basically, the differences are very subtle, and it could cause a diagnostic confusion. Now, how do you treat CAPS? So the gold standard is used to use a triple combination. You have to combine anticoagulation with immunosuppression. So you use corticosteroids, anticoagulation, and plasma exchange, or you can use IVIG. For in SLE patients with CAPS, you preferably use cyclophosphamide, and sometimes you use rituximab. And when you talk about anticoagulation, you basically use unfractionated heparin, and it is usually given for around 7 to 10 days. So plex, usually initial days you have to do daily plex, and then IVIG is reserved for refractory cases. Okay, and in the ICU you have to minimize the arterial instrumentation and follow the other standard procedures. So coming to this case, this is basically a patient with upper airway involvement in the form of crusting, epistaxis, ear fullness, left eye scleritis. Then the patient comes with a rapidly progressive renal failure. Okay, so we get the call at night because the patient is having a pulmonary edema and oliguria. He has got active sediments in the urine. So the diagnosis is very straightforward. The renal biopsy has already been done, so it is showing crescentic glomerulonephritis. So this patient is having a GPA with a rapidly progressive renal failure and flash pulmonary edema secondary to hypertension. So this patient was managed with pulse methylprednisolone and IV cyclophosphamide, and he made a good clinical recovery. So GPA, MPA, and EGPA belong to the ANCA-associated vasculitis spectrum with subtle differences in the organ involvement. For example, you get a typical triad of upper respiratory, lower respiratory, and renal in GPA, whereas your lung and the renal are more commonly involved in MPA, whereas EGP has more of a sinus involvement along with peripheral nerves. And there is difference in the relapse rate and the treatment response also in these patients. So when you talk about rapidly progressive renal failure, so you have type 2 and type 3. Type 2 is basically immune complex mediated, which is usually caused by things like lupus and cryoglobulemic nephropathy, or your C3 glomerulopathy, whereas type 3 is basically secondary to ANCA-associated vasculitis. So, and the most common presentation is basically nephritis presentation with hypertension and active renal sediments. So the treatment here is basically pulse methylprednisolone with cyclophosphamide or rituximab, and plasmapheresis is usually given on a case-to-case basis. So you don't use plasmapheresis in all patients. It is a conditional recommendation to give the plasma exchange in patients who have anti-GPM antibodies. Diffuse, along with this patient also has diffuse alveolar hemorrhage or a baseline creatinine more than 4. So it's basically a conditional recommendation. So coming to this patient who has got a 28-year-old lady who's got palpable purpura. Okay, so she also has oligoarthritis, and she's in the ICU because of acute abdomen with severe abdominal pain and vomiting. You can see the total count, which is very high, 18,500, and high CRP. So this is the lower limb palpable purpura on the lower limbs, and you can also see the abdomen, the CECT abdomen showing diffuse bowel wall edema. So this patient is having IgA vasculitis with GA vasculitis, secondary GA vasculitis. So GA vasculitis is basically a emergency because these patients can go for perforation, peritonitis, etc. So coming to GA emergencies in rheumatological disease, this could be acute mesenteric ischemia, mesenteric vasculitis. Lupus can come with lupus pancreatitis or lupus enteritis. They can come with peritonitis, pseudo obstruction, and it could also be secondary to the drugs, drug-induced gastritis, drug-induced pancreatitis, etc., etc. So immunosuppression by itself can cause infections in the GA system. So gastrointestinal emergencies are not rare in rheumatological diseases. So how do you treat? You have to treat the basic disease. You have to give bowel rest, PPAs, and other supportive measures. For pan or polyarthritis nodosa, you basically give cyclophosphamide induction along with glucocorticoids. For hepatitis B related associated pan, you basically have to combine antivirals with plasmapheresis. Okay, and deficiency of ADA2 is basically a novel autoinflammatory syndrome, which it's a type of medium vessel vasculitis. These patients can also have GA involvement. So here the treatment of choice is anti-TNF alpha. So other diseases, in ANCA again you go for cyclorituximab, and in lupus you can go for cyclophosphamide. So now this patient is a 44-year-old lady. She comes with acute onset flaccid quadriparesis with severe hypokalemia and impending respiratory muscle weakness. Okay, so VBG is showing a normal anion gap metabolic acidosis. Okay, the immunological profile shows a 3+ speckle pattern and strong positivity for anti-SSI. Okay, so here we are dealing with primary Sjogren. Okay, primary Sjogren disease with a distal renal tubular acidosis and hypokalemic paralysis. Okay, severe hypokalemia secondary to the tubular interstitial nephritis. So this patient was treated with IV KCl and lifelong potassium supplementation. So if you don't intervene in this patient, the patient will go for a hypokalemia related complications. So when you talk about Sjogren, our classical understanding is that these patients will come with dry eye, dry mouth. So this is basically a series where they showed around 13 patients came with only hypokalemic paralysis with even respiratory muscle weakness. So this could be the initial manifestations, and only 8 patients had any involvement of the exocrine gland. So Sicca symptoms or the dry eye, dry mouth may not be present in a good number of patients also. So you have to evaluate for Sjogren's in any patient with a hypokalemic paralysis. So neurological emergencies can start from the higher mental function itself. The patients can come with acute confusion state, aseptic meningitis, acute demyelinating syndromes, can be something like a ADAM like encephalitis. They can come with severe transverse myelopathy. Rheumatoid arthritis patients can come with severe acute onset quadriparesis secondary to atlantoaxial dislocation, and your primary vasculitis can involve any part of the neuraxis. Inflammatory myositis, what is most important is this patient can come with a severe respiratory muscle weakness. Okay, if you don't intervene in time, you might lose the patients. So coming to this patient, this is a 30-year-old young lady with constitutional features, acute onset dyspnea, and she also has got high inflammatory markers, and she's got a aortic regurgitation and some features of pulmonary edema. Okay, so this is a young patient, any young lady coming with a acute onset heart failure, okay, which is which we don't have a clear cause, we have to rule out Takayasu arthritis. Okay, so this patient's CT aortogram basically showed severe wall thickening, especially in the carotids and the subclavian, and she was diagnosed with a Takayasu arthritis with severe AR and acute pulmonary edema. So she was treated with corticosteroids followed by mycophenolate. Ideally the drug of choice should have been cyclophosphamide, but she had not completed her family and she was not willing for the same, so we had to give her tocilizumab is another option, but because of financial constraints we could not give her. So we went for mycophenolate, and the repeat echo at 3 months, the ejection fraction had significantly improved up to 40%. Okay, and then once she was clinically in remission, we went ahead with the aortic valve replacement. So Takayasu arteritis should not be forgotten in any patient coming with a acute onset heart failure. So cardiac emergencies could be myocarditis, endocarditis, or even pericardial effusions, severe pericardial effusions. So your myocardial biopsy is very useful, but it is not performed because of the invasive nature. You can go for a cardiac MRI because it's very sensitive and specific for picking up myocardial inflammation. So the treatment is basically again with high dose methylprednisolone pulse therapy with cyclophosphamide for the life threatening features. So cardiac involvement, as I told you, it can involve the valves, it can cause the vascular structure causing aneurysms, it can present with cardiac arrhythmias, new onset cardiac failure, or cardiomyopathy. So this patient is a 44-year-old male. He came with polyarthralgia and he's got a photosensitive rash and he is very dyspneic. He is hypoxemic on admission. So if you look carefully, you can see a small little ulcer here on the third MCP, and you can also see the tender papules on the palm, on the tip of the fingers. So he's got tender palmar papules. You can see the ILD here, interstitial pneumonia with a, what is this? You can see a pneumomediastinum. Okay, so you've got an ILD with a rapidly progressive respiratory failure and a pneumomediastinum. So that is enough to diagnose a anti-MDF5 associated dermatomyositis. This is a life-threatening form of inflammatory myositis, and if you don't intervene, so these patients can go for respiratory failure. So ILD is seen around 60 to 100%, and rapidly progressive ILD is seen around 40 to 70% patients with anti-MDF5 disease. The radiological pattern can vary from OP to NSIP, and these patients with this hallmark antibody have got a 20-fold higher risk of developing RPILD compared to anti-MDF5 negative dermatomyositis patients, and the 6-month mortality rate is close to around 50 to 70%. So it means only 1/3 of the patients will be alive at 6 months. That's very dreadful. Now there are some baseline predictors: patients who have high serum ferritin levels, high serum LDH, high titers of anti-MDF5, patients who have Rho52 antibodies, elderly age. These are more likely to have a rapidly progressive phenotype. So how do you treat these patients? Time is very crucial in these patients, and there is no RCTs to support our treatment decision. So we go by the case series or retrospective data. So a triple combination therapy involving high dose glucocorticoids with cyclophosphamide and calcineurin inhibitors like cyclosporin or tacrolimus could be used as one of the life salvaging therapy. So these patients are quite refractory also. So what do you do in refractory patients? You can go for other options like rituximab, mycophenolate, or if they are very refractory, you can go for plasmapheresis or IVIG. Okay, so plasmapheresis and IVIG are to be used in the early phases, because these patients may not survive beyond 1 month, and you have to always have a conversation with your lung transplant team. If your center has got a facility for lung transplant, be in connection with them, be involved with them, and if you have ECMO, that is again another facility which can be utilized as a bridge to lung transplant. So this is basically a small series showing our experience with this deadly disease. So we had around 5 patients out of 9 anti-MDF5 patients, only 5 had RPILD. So around 55% of patients had this phenotype of rapidly progressive ILD, and all patients had polyarthritis without any muscle weakness, and the ANA was negative. So classically we use anti-nuclear antibody as a screening test for connective tissue disease, but these patients are negative on ANA, and we have used combination therapy in almost all patients, which includes pulse methylprednisolone, cyclophosphamide, tacrolimus, or MMF. And 2 patients we have lost, and we lost the patients very early. Within the first 2 weeks of admission, we lost the patient, and the rest who have survived have actually lived for around 3 to 4 years. So it means the survival is good once they are out of this acute phase. So high serum ferritin and high serum LDH were seen in those patients who expired. This basically shows that these can be used as biomarkers for understanding the survival. So other rheumatological emergencies which I have not covered in this presentation include septic arthritis, acute digital gangrene, acute limb ischemia, scleroderma renal crisis, gout flare, hemolytic crisis in lupus. So these are all things that you might see in the ICU, but because of time constraints, I have not touched upon that. So my take home message is that rheumatological emergencies are not uncommon. So they can be associated with significant mortality, and you have to have a careful view of this patient. You have to take a careful history, meticulous clinical examination, and judicious investigations, especially needed to differentiate a disease flare from a secondary infection or a drug-related side effects. And early diagnosis and initiation of appropriate immunosuppressive therapy might be life-saving. Thank you.
So, good evening, everyone. So, we'll, after very exhaustive academic session by Dr. Hari and all others for the previous few days, hi, my classmate. Okay, so so I would like to take you all to a lighter session, and just as an introduction, I would like to tell you we don't like to send our patients to ICUs. Do you know why? We maximum keep the patients whom we have with us only. Maximum at breaking point എത്തുമ്പോഴാണ് we shift them to ICU. Otherwise we keep them with us only. Whatever issues we have, whatever effort we have to take, we don't try to push them to ICU. I would like to have your opinion on that. What would be the yeah, one is infections. Very good. Very good, very good. That's what I wanted to get from you. Skincare. Skincare is something which we don't learn in MBBS. We don't have a topic on nursing, not just dermatological nursing, nursing for any reason. So we are not very aware of that part. So when we have a patient in ICU, once they are out of the ICU, maybe their systemic features would have systemic complications would have been addressed, but usually the skin condition worsens, and they may also get some other infections from the persons there are already in your ICU setup. So we don't like ICU, but still I would like to use this opportunity to sensitize you to a few conditions which you should be aware of. You should not be missing, and also some little things which may not be asked in your exams, but I feel that should be conveyed to you. Okay, so it will be an interactive session. So what are the conditions that you get to see in ICUs related to dermatology? 1, 2, 3. Stevens-Johnson syndrome. Varicella, do you get it in ICU? No. But the moment you get in ICU, you shift them to other places. No, it's not an ICU functions as isolation also. Okay, fine. In ICU, you have isolation. How does varicella complications land up in ICU? Pneumonitis, encephalitis. Okay, fine. Okay, any others? 10 is actually a variant of SJS. Any others? Necrotizing fasciitis related to sepsis. Okay, fine. Bed sores. Does it come under your criteria for ICU care? I don't think. Psoriatic flares. Which kind of a psoriasis? Pustular psoriasis. Very nice. Generalized pustular psoriasis. Then anything related to that? Extensive skin involvement. Bullous pemphigoid? No, pemphigus actually. Pemphigus. Bullous pemphigoid is a milder disease. Though it's there in your journals and all, it's not a very severe disease. Usually they don't go to SU and all. Okay, fine. So, do you know any term similar to your other organ failures by which our patient ends up in ICU? Have you heard about any failures related to skin? It's simpler than that. Skin failure. Just it's called skin failure. Okay. So what are the functions of skin? You know, barrier function. Very nice. Thermoregulatory function. Sensation. That's a minor one. Okay. Related to the ICU context. Okay. What are the other sensations? What are the other functions? You missed a major one. Thermoregulatory function. That you already mentioned. One more. Any other balance skin is keeping? Yes, yes, fluid electrolyte balance. So these are the major functions of skin. So when one of these functions is lost or more than one is lost, we call it acute skin failure. Okay, so this is the main dermatological emergency that lands up in ICU. Okay, and this is the patient that I wanted to keep with myself, not to send to your ICU as well. Why? We'll know. Okay, so is this working? It's working. ഇങ്ങോട്ട് കാണിച്ചാ. Can you hear? കേൾക്കത്തില്ല. ഇത് ഓഫ് ചെയ്താൽ കേൾക്കാവോ? ഓക്കെ ഓക്കെ ഫൈൻ. അപ്പൊ ഇവിടെ കേൾക്കുള്ളൂ ഹാൻഡ് മൈക്ക്. So I'd like to be in between you. Okay, fine. So these are the functions we mentioned. So these are the functions that will be lost. So loss of temperature control. What will it result in? Hypothermia can cause poikilothermia. Also can also cause hyperthermia. Okay. So mostly it is hypothermia. So that is why the patients. How are you? That is why the patients are usually very uncomfortable, not dressed, and they have shivering. So one main important thing you should take care is keep them well dressed, give blankets, etc. Okay. Then failure to prevent percutaneous fluid protein electrolyte loss. That can happen in many ways. Before this, I would like to show you the causes. Then you can understand better. So first one causes erythroderma. Erythroderma means any condition, any skin condition which can cause scaling and erythema involving more than 90% of body surface area. Okay, it can be psoriasis, it can be eczema, it can be a post-inflammatory scaling after an acute generalized pustular psoriasis. So any condition which causes more than 90% erythema and scaling is what is called erythroderma. Second is you mentioned as STN, then acute generalized pustular psoriasis, a severe variant of psoriasis. Then immunobilous disease like pemphigus, also infections like Staphylococcal scarlet skin syndrome, usually seen in pediatric ICU. Are there pediatricians here? No. Okay, fine. So, so fluid loss can occur, electrolyte loss can occur. Also, there are other things that are lost, like through scales, what are lost? Iron, protein, micronutrients, very nice. Okay, all these are also lost. And also the failure of barrier function, which results in secondary infection sepsis. So this is what is mentioned in the coming slides. This, once there is acute skin failure, there is vasodilatation of the cutaneous vasculature. So peripheral vasodilatation occurs. So all the internal organs get lesser supply. Due to the peripheral vasodilatation, there occurs edema, erythema, and also the hypothermia that we mentioned. And this can also result in acute high output cardiac failure. Okay. Then other reasons, there will be increase in basal metabolic rate, which can cause hyperglycemia. Shivering, I already told you. Increase in protein catabolism. So there will be negative nitrogen balance and muscle wasting. And this is what I was mentioning. What is the normal water loss per skin? Around 400 ml. Around 400 ml per day. So this will increase to around 3 to 4 liters per day when there is more than 50% body surface area involved by a condition like TN. Okay. And also other things will be lost in fluid like sodium, potassium chloride. It can also cause hypophosphatemia, hypocalcemia. Hypocalcemia is especially important in pustular psoriasis. Hypocalcemia can trigger pustular psoriasis. Similarly, pustular psoriasis can cause hypocalcemia. Okay, so always do calcium for your pustular psoriasis patients. Then other things lost, protein is lost, iron is lost, I already told you. So there can be hypoalbuminemia, anemia. Hypoalbuminemia can result in peripheral edema. Anemia can cause all the other complications, including cardiac failure. I'm not going into the details, you know all those things. Then other systemic complications like ARDS, bone marrow suppression, and finally sepsis. Okay, so these are the things you are going to deal with. So I would like to just sensitize you when to recognize a condition, dermatological condition in your ICU, or to manage the specific dermatological management side of these conditions. Okay, rest you know better than me, so I'm not touching those things. And these are the long-term complications. This we'll discuss again. So what is SJS? It is Stevens-Johnson syndrome. Stevens. Okay. So what is SJS? What is the difference between SJS and TN? What happens in SJS? What causes SJS? Drug. Mostly it's a drug which causes SJS. Okay. So they take a drug. What happens? Yeah. Manifestation is actually erosion which happens after a charring. So basically it is keratinocyte necrosis that is happening. Okay. Or you can say apoptosis also, because it is fast ligand interaction, cytotoxicities, multiple pathways involved. Finally what happens is keratinocyte necrosis. So keratinocyte necrosis result in some charring like this. So whenever you see a charred lesion, you know what is charring? Karinja pole. All are Malayalis. Yeah. So charring, you get a charred lesion or a purpuric macule. That shows that there is keratinocyte necrosis happening and it is a detachable skin. It can sometimes blister out, sometimes it can peel off like a sheet. Okay. So the patient will also have a prodrome fever, malaise, and later on they'll develop multiple purpuric macules, sometimes blistering, then they'll all form erosions. This happens in the mucosa also. So this is how SJs presents like, and based on the percentage of detached or detachable skin involved, we classify it into SJs, SJS-TN overlap and TN. Okay, if it is less than 5% SJs, 10 to 30 is overlap, more than 30 is TN. Okay, fine. So you have to calculate the detached and detachable skin also. Purpuric macules and the erosions and the blisters. Got it? So how do you calculate the percentage? How do you assess it? You can use the palm rule or rule of 9. Anyway, you can count it and find out how much it is. Okay. And the most common drugs are antiepileptics, allopurinol, sulfonamides. Okay. Usually it happens 1 to 3 weeks after the drug. Usually we get the patient within 7 to 10 days. Okay. And the problem we find in ICU is patient will be on multiple drugs. We'll find it very difficult to find out the culprit drug. And the only way out is to try stop everything which is taken prior to the onset of peeling. Okay, so one advice I would like to have is Dr. Netto must also have told you. Try to avoid maximum drugs as possible. Give only the most essential ones. Because once drug reaction happens, we are in real dilemma. If you give multiple like antibiotics, you try to cover everything. You give all sorts of antibiotics. Once SJS is diagnosed, and you start it on the same day also. That's another finding we see. Okay, if you don't get response, you can start it on the subsequent days. But usually the trend we see is they start everything on the first day, and finally we are nowhere where we cannot find out which is the drug that actually caused, and we will be forced to stop all the drugs that we started. So try to avoid polypharmacy. Not only antibiotics, all other supportive drugs, Pantop, whatever you add on, if not necessary, please avoid. Okay, this is not only for ICU, anywhere you go. I don't write Pantop with Moxclav or Doxy. I've seen people writing. So don't write that. That is the most important thing. Avoid maximum drugs as far as possible. As this I learned after I joined MD. Otherwise, I also used to write Rantac and Pantop with everything that I write. So avoid that polypharmacy because you can get reaction to anything under the sun. Okay. So other triggers are vaccines and sometimes SLE and all can also present. Okay. Infections. And this will also be associated with mucosal erosions like this. There is a scoring system called SCORTED. I don't want to go into details. These are the parameters which are assessed. You can assess it on the first day, you can repeat on the third day, and also so on. And you can find it. Maybe the patient coming on the first day will be area less than 5%. But by the third day, patient will become TN. That is possible. Okay. So this has to be assessed. And the important thing is the mortality with one factor is only 3%, whereas with more than 5 factors, it is 90%. So it jumps. Okay. Fine. And the other complications, almost all we mentioned. Only thing I would like to mention additionally here is your skin care and mucosal care is very important, because usually patient gets out of the SJS part, but the sequelae remains. Like the eye care that may not be properly taken care of, so that will result in symboliform blindness, etc. And ophthalmic consultation should be given early and if needed even repeated daily. Okay, because every day it may change. One day there may not be symboliform, next day they can develop corneal erosion. So you have to cut. Yeah. You said they don't. One see, documentation is another important thing here. See, have you heard about a case in Thrissur? There was a case, I think in Thrissur, some northern side, a child with SJSTEN. The pediatrician was sued only because the child developed blindness later on. Why? Because they didn't send a consultation. So it's your duty to send consultation daily if needed, anyway on the first day, and to have reassessment. If it is not sent, it will be your fault. Okay, if it is sent, and you can also try and insist them to see also. Okay, because it is a definite morbidity the patient is going to carry after the SJS part is over. And another mucosa also like dysphagia, nasal mucosa, gingival mucosa, oral hygiene and oral care is very, very important. Once the patient can brush, they can use a soft toothbrush. You can also advise other methods like mouth washes and other oral hygiene care. Okay, and also the vaginal mucosa, labial adhesions we see bulbar posthitis and phimosis. All these things has to be taken care of during the acute stage itself. You should not wait for the SJS to subside. Okay. Okay. This already I think I'm going back. Okay. So, okay. So, management principles. First thing, if it is drug, stop the drug. So, suppose the patient is on pantoprazole, you suspect pantoprazole, the patient is also on fluconazole. What do? You have to stop both. It is a structural stimularity that produces, and you have to avoid in future also. Suppose you develop drug allergy to pantoprazole, the patient has to avoid ideally all azoles. Can you tell a few azoles? Fluconazole, all antifungals with azole. One more. That all comes under antifungals. Some other azole use. That's all antifungal. You will not think about this. That's why I asked. Pantoprazole, okay. So pantoprazole, rabiprazole, omeprazole all comes under that. Ketoconazole, fluconazole all comes under that. Any other azole use? Tell. Antibiotic and helminthic. Albendazole. One more you can say. Metronidazole. Very nice. So all these azoles can cross react. Okay. This is the thing you have to keep in mind. Whenever we write stop and avoid the drug and structurally related drugs, you have to think about all the structurally related drugs. You can even ask the dermatologist which are the structurally related ones. Okay. And also another thing is with phenytoin. Which one do you avoid? Phenytoin, of course. Usually write an essay. Which all other things to be avoided in phenytoin drug allergy? Phenytoin, phenobarbital, carbamazepine, lamotrigine. All these have the same aromatic thing, and so all has to be avoided whenever one is having allergy. That we usually write. You send consultation to a dermatologist, they will naturally write avoid all these. And sometimes we ask sodium valproate also in the acute stage because that plasma protein binding issue. Okay, so these are the things you have to take care of. And so of course it requires a multidisciplinary team, dermatologist, ICU team. Nursing care is very, very important. You can give an ambient temperature 30 to 32 degrees Celsius because of the issue of hypothermia and other things. Monitor vitals. I'm trying to skip. Enteral feeding has to be encouraged. Try not to put an isogastric tube maximum possible because already the skin is peeling off. Okay, that activity, phospholigand activity and keratinocyte necrosis is happening all over the body, though it's manifesting only in a small area. So wherever you try to initiate trauma, you can develop erosions, including the airway as well as aerodigestive tract. So what is it called? What is that sign called? You slide over the epidermis. Nikolsky, very nice. So that is Nikolsky is actually positive in pemphigus. This is pseudo Nikolsky. Okay, I'm not going to details, but you can assess the activity by just sliding over the epidermis. You will get a detached epidermis. That's called Nikolsky, pseudo Nikolsky here. Okay. And fluid requirements, is it more than or less than burns? It's less than burns. It's less than burns. Okay. And usually crystalloids are preferred. There are guidelines. You can refer the guidelines later on because I cannot cover everything here. There is Indian Academy of Dermatology IADBL guidelines on SJSTN management. You can refer that, how to give fluid, how to give calorie, everything is there. And protein diet also has to be advised, calorie intake, and everything preferably through mouth. Okay, parental maximum avoid, and also avoid maximum catheterization. Maximum invasive procedures you avoid. Even when you apply a plaster, that will create a erosion. This is applicable to both SJST as well as pemphigus and all other conditions where it's a generalized skin peeling, even SSS also. And pain management, this all you know. I'm not going to enumerate on that. Then strict aseptic precautions, barrier nursing, hand hygiene, and also what I have seen is you try to occlude the erosions. Don't you try to dress. We tend to keep it open because it is not actually infected. Okay, when you keep it, you can keep it closed if you can apply a sterile Vaseline gauze and close it. So wound care depends on certain factors. If it's infected, we tend to keep it open mostly. If it is sterile wound and you think that you can get infection from the surroundings, you can keep it closed. But usually, and also if there are blisters, don't cut them open. Okay, don't create raw areas because skin is the best cover you have. If there are blisters, you can just put a nick and let out the fluid if it's the pressure is causing pain. Otherwise, don't do that also. If they are flaccid, leave them alone. Okay, and for the erosions, you can apply sterile Vaseline gauze. It's available as various brand names. So you can apply it with sterile precautions and apply your dressing. Okay. Then, okay, antibiotic policy. I think Dr. Netto must have told you to avoid antibiotics as much as possible, but most of the time we tend to start a prophylactic antibiotic because the skin is so much gone. And wound care, non-adhesive dressing, petrolatum gauze that I was mentioning. Then, if possible, encourage them to take bath. That is the best cleansing. Okay. I don't know what is your setup, but if the patient can take a bath, that is the best thing would be. I know it, but what I tell you is the best cleansing method would be than using a wipe or a whatever. Just you pour water, that will be better than wiping it off. And there is something called saline compress. I'll tell you about that later on. Ocular care, I told you, do it in consultation with an ophthalmologist and if possible daily review. These all you know. What is the specific therapy? Steroids. That has to be started at a higher dose early enough because it can be given only during the acute phase, during that fast like an interaction and the apoptosis. After that, there is no use. After that, if you give also, it will only add on to your chance of sepsis. So you have to give steroid early enough, high doses, stop it by 7 to 10 days. Okay. And cyclosporin is another option, IVIG, plasmapheresis are all options. But usually patients respond to steroids once the culprit drug is stopped. And if not improving, you have to suspect you may be continuing the culprit drug. Or it is some other cause which is causing TA. Okay. And documentation. Proper documentation. Another thing we usually come across is we may see consultations in ICU. Once they're discharged, in the discharge summary, it's not clearly written what is the type of drug reaction. Because different type of drug reaction, some can be challenged, some cannot be challenged. So what the dermatologist has written, like SJSTN, if it's SJSTN, it cannot be challenged, okay? And also which is the drug and which all are advised to be avoided, that you have to clearly write. And that's all I told you. Pharmacovigilance, you know. So coming to another topic, pemphigus. So you can refer to the SJSTN guidelines in IDVL, and also there is a journal called Acute Skin Failure that must also be helpful for you. I can share it in the group, okay? Next, pemphigus. What happens in pemphigus? It's same as acute skin failure, another condition which causes acute skin failure. So what happens? There is antibody against the desmogleins or the intercellular cementing substance. So the cells cannot remain attached to each other. So there is space between the cells resulting in blisters. This happens in the skin as well as in the mucosa. Okay, so they gain acute skin failure. But the problem is this will continue. So you have to continue your immunosuppression. Autoimmune condition ayadondu. Other one, when you withdraw the drug, that's gone. So by 2 weeks, your SASTN will be completely cured. Only sequelae may remain if you have not addressed the or prevented the sequelae. But pemphigus patient will be a chronic patient with you for around 5 years or 8 years. So this is the Nikolsky sign. You can apply tangential pressure on a normal looking skin. Okay, it can be near the lesion or away from the lesion on a bony prominence. You apply tangential pressure, you can see that the skin slides over. That's called Nikolsky sign. It shows that even the normal looking skin is having pathology. Okay, how do you treat pemphigus? Steroids, high dose steroids. Then other options. Now we have a lot of options. Which monoclonal antibody? Rituximab. Now it's becoming almost first line. We are giving rituximab as almost first line. Okay. And then other immunosuppressants like azathioprine, methotrexate, depending upon the disease, and also other general care, whatever I have mentioned. What is this? This is what is acute generalized pustular psoriasis. The patient may have a previous history of psoriasis, may have psoriatic plaques on the body. Sometimes it can occur de novo also. Okay, and there will be multiple sterile pustules. This is actually you must have learned in your MBBS neutrophil, Monroe's microabscess. All these are neutrophil collections. So when this becomes severe and becomes macroscopic, that's what is called pustular psoriasis. Neutrophil is equal to pus. So when the microscopic pustules become macroscopic, it results in pustular psoriasis and the patient will be toxic. There is a subacute annular variant which is usually subacute. It does not require much of a severe nursing care, but generalized variant called von Sumbusch type, the patient will be toxic. He will have all other systemic complications, aseptic pneumonitis, multiple serositis, arthritis, etc. Sometimes patients become also. And these are all sterile pustules. You can see lakes of pus. Can you see multiple pustules will coalesce to form lakes of pus. Patient will be very toxic. Sheets of erythema will be there. On the sheets of erythema, there will be pustules. See, this is the lake of pus. Okay. How do you manage? In supportive care, but you will have to start on some of the disease modifying agents. Like, any of them. What will be the crisis buster? Cyclosporin. Usually cyclosporin is the fastest acting if you keep aside steroids. But steroid is, do you give steroid in psoriasis? No. Systemic steroids are actually contraindicated in psoriasis unless we don't have any other go. Like patient is in very severe metabolic derangement, you have no time even the cyclosporin to act, something of that sort. Usually we don't take, if you start steroids in systemic steroids, I'm talking, not topical. Topical is the mainstay of treatment for any psoriasis, but systemic psoriasis is contraindicated in psoriasis except in very few indications like pustular psoriasis in pregnancy, metabolic derangement, your psoriatic arthropathy, very severe psoriatic arthropathy. What will happen if you start steroids in psoriasis? Why do you don't want to start? Not immunosuppression. These are more immunosuppressive than others. Whatever we otherwise give. Methotrexate, cyclosporin, secukinumab, ustekinumab. That are the ones we usually give other than steroids. But what happens with steroids? It will beautifully respond to steroids. You give a stab dose of dextrona, next day patient will be okay, 100% okay. But you don't give that, right? Yeah, very good. Yeah, rebound. You cannot stop. It's like riding on a tiger. My professor used to say that like that. You can keep on riding. You cannot step down. Once you step down, the tiger will eat you. So if that will be the same thing when you start steroid or a psoriatic patient. Systemic steroid. Okay. So the drugs of choice, usually the crisis first will be cyclosporin, or you can give acetaminophen. Methotrexate is another choice, but methotrexate will take time to act. Then now we have biologicals, secukinumab, ustekinumab, etc. Okay, I'll have to erythroderma. Already I mentioned scaling erythema, more than 90% of area, any condition, eczema, atopic eczema, allergic contact dermatitis, seborrheic dermatitis, psoriasis, anything can cause this. So find out the cause, treat the cause, and also all the supportive care. Usually chronic erythroderma does not require IC care. Okay, it's acute erythroderma. Usually the drug-induced erythroderma, which is acute, requires ICU care. It will be associated with all the complications mentioned. What is this? I have named it. What happens in SSS? What happens? It's almost similar to your pemphigus. It's not antibody. That is the difference. What causes? Toxins. Which toxin? Of which organism? Staphylococcal. Staphylococcal exotoxins cause what? How does it cause? Finally, what does it cause? It causes blisters. So how can blister occur? Acantholysis, same as pemphigus. In pemphigus, it is desmoglein 3, and in foliaceous also it is desmoglein 1. It is desmoglein 1 here. Okay, it's almost similar to pemphigus foliaceous. I'm now making it more complicated by mentioning foliaceous because I know you don't know about foliaceous. So desmoglein 1 is effective. Okay, desmoglein 1 is lysed by the toxins, and that causes blistering. Usually the child will be toxic again, irritable, fever, constitutional features. It may start in the periorificial perioral area. So a scaling, peeling in the periorificial perioral intertriginous area in a child who is sick, it may progress to SSS. Okay, and why does SSS occur only in child? Mucosa will be spared. Okay, usually spared, only skin will be involved. Whereas in pemphigus, it is both mucosa and the skin involved. Pemphigus in the foliaceous variant will have similar picture without mucosal involvement. Anyway, here mucosa will be spared, and it is a very superficial blistering, subcorneal level blister. Okay, it is suprabasal, it is a little more deeper. Leave it. Coming back to the question, why is pediatric population is involved? Why don't adults get this? Diaper അല്ല അഡൽട്ടും ഡയപ്പർ യൂസ് ചെയ്യുന്നുണ്ടല്ലോ ചിലപ്പോൾ. Yes. What is immature immunity? They cannot neutralize the toxin. Any other reason? Immature skin അല്ല, some other immature thing. You can answer it if I reverse the question. Which group of adults get SSS, if at all they get? Immunosuppressed one. Second, renal failure. So it is an immature kidney which cannot excrete the toxin. So SSS can occur in adult if immunosuppressed or renal failure. Okay. So that is SSS. How do you treat? All the general care, whatever I mentioned, then plus which antibiotic? Anti-staphylococcal antibiotic. Where is the portal of entry here? Can you get culture positive here? Blood culture ആണ് positive കിട്ടുന്നത്. Blood culture positive actually കിട്ടണമെന്നില്ല, toxin ആണ് actually. The portal of entry must be long back. കുറച്ചുകൂടെ പുറകിലൊരു ടോൺസിലൈറ്റിസോ ഫെറിഞ്ചൈറ്റിസോ അങ്ങനെ ആയിരിക്കും. And that causes the release of toxin. The toxin is hematogenously circulated. It's not actually a real septicemia. It is a toxin mediated disease. Which is the other toxin mediated disease? Skin related. Streptococcal? The toxic shocks. No, one more is there. Streptococcal toxin mediated where not emergency. Erysipelas. Erysipelas is a localized disease. Erysipelas is skin direct bacteria. Toxin, scarlet fever. Scarlet fever ആണ് streptococcal toxin mediated disease. അതിൻ്റെ ക്ലോസ് ഡീഡ് ചെയ്താൽ അതും ഐ സിയിൽ എത്താം വേറൊരു വഴിക്ക്. കവസക്കി പീഡിയാട്രിക് ഐ സിയുവിൽ എത്താം. അപ്പം കവസക്കിയുമായിട്ട് ഡി ഡി വന്നിട്ട് scarlet fever may be a very close DD. It's very difficult to differentiate sometimes. And most of the time we write rule out Kawasaki by doing whatever investigation is possible because we can, that's more dangerous, no? Okay. Toxic shock syndrome, about what you mentioned. This you know. Previously it was due to the tampon use. So it can cause again toxin release, streptococcal and multi-organ failure as hypotension and shock. Okay. And rash will be macular, sometimes even papular also. The problem is rash cannot distinguish all these conditions. You will have to take everything into consideration. Have you seen this? Unlikely to see, but this is what is called purpura fulminans. Purpura fulminans means you are seeing purpura. Purpura means what happens in purpura? Bleeding into the skin. So there is microhemorrhage happening. There is thrombosis happening. It can happen due to various causes. It can be an acute infectious purpura fulminans, most commonly associated with meningococcemia. Usually seen in a setting of meningitis, and also sometimes where there is asplenia. Asplenia is another setting where you see. Then neonatal purpura is usually a hereditary deficiency of the protein CS deficiency, or it can be an acute idiopathic purpura that occurs usually after an infection, 7 to 10 days after a varicella or any other infection, you get a purpura. The most common one is the acute infectious purpura, usually by meningococci. Okay. As I mentioned, again treatment of the cause, find out the cause, treat the cause, and supportive care. And this actually usually does not land up in ICU, but I will always mention this even if it is not related to this thing. We can mention it as they can land up in ICU, but not very common. What is this? Dress. I would like to ask you a question. See, one patient comes to you who has been on phenytoin for last 2 months or 1.5 months, and they come with rash, pruritic rash, itchy rash. Okay. Forget about this class and tell me honestly, the patient is asking, is this due to the drug? What will you say? Will you say this can be due to drug or not due to drug? How many of you will say yes, it can be due to drug? Anybody here who will confidently say it is due to drug? A patient on phenytoin after 1.5 months of starting phenytoin, continuing on phenytoin, they are asking, is this rash probably due to drug? Just your relative, you think it is your relative or your friend. Honestly, what will you say? I want that an honest answer. I know this is a leading question, you can answer either way, but honestly, any among this group of people will answer yes? ഉണ്ടോ ആരെങ്കിലും അങ്ങനെ കോൺഫിഡൻ്റ് ആയിട്ട് യെസ് എന്ന് പറയുമോ? അതുള്ളതുകൊണ്ട് കൊള്ളാം, അല്ലെങ്കിൽ പറയുമോന്ന് എൻ്റെ ചോദ്യം. ഈ സ്ലൈഡ് വരുന്നതിന് മുമ്പ് ആരെങ്കിലും ഇവിടെ യെസ് എന്ന് പറയുമോ? പറയത്തില്ല, ഞാനും പറയാറില്ലായിരുന്നു. ബട്ട് this you should suspect. ആ ഒരു സിനേറിയയിൽ there is no other condition other than dress. Okay. Dress rule out ചെയ്തിട്ടേ ഉള്ളൂ വേറെ എന്തിനും possibility. A patient on phenytoin or any other drug, the incubation, the latent period is around 2 to 8 weeks. Dapsone is another drug which is very common. Dapsone syndrome എന്ന് പറയുന്നത് 5 weeks syndrome എന്ന് പറയാറുണ്ട്, because 5 weeks ആണ് latency. അപ്പോൾ ഒരു 5 to 6 weeksൽ patient continuing on drug coming to you with rash, and this will very, very closely mimic a viral rash. They will have fever, they will have lymphadenopathy, they will have rash. When you check, they will have cytopenias or even increased counts. They will have increased ESR, CRP, RFT, LFT, anything. So this is a very, very, very close mimicker of viral exanthem. So keep this in mind, and when you So you can expand it and see drug reaction with eosinophilia and systemic symptoms. That eosinophilia can be a catch. But another issue is patient may have otherwise eosinophilia due to some other cause. That you can check by having a baseline test if you have. Baseline CBC undegi, you can compare it with the present one and confirm it. Okay, and usually it is anti-epileptics. Allopurinol can cause, but what is the difference between SGSTN and this one? Onset is delayed. Rash can be anything. Blistering on the avanamilla. Either there are rash vera. Even erythroderma vera. TN like rash vera. But TN patient ee baki systemic features undegi, sometimes we take it as a TN like DHS. Okay, അപ്പോൾ rash ഇവിടെ എന്ത് rash എന്നുള്ളത് significant അല്ല. Any rash occurring in a setting which I have told you, you have to suspect RAS. Okay, and what is other difference from TN? Organ damage. Very good. അവിടെ organ damage വരാം, പക്ഷെ ഇവിടെ കൂടുതൽ വരാം. പിന്നെ lymphadenopathy, eosinophilia. ഒരു ട്രീറ്റ്മെന്റ് ആസ്പെക്റ്റിൽ withdraw ചെയ്താലും this may continue. Okay, why? This is a type 4 hypersensitivity. Type 3 യുടെ കുറച്ചുണ്ട്, type 4 ആണ് കൂടുതൽ. Type 4 എന്ന് വെച്ചാൽ ഏതാ? Delayed ആണ്. അതുകൊണ്ടാണ് delayed ആയിട്ട് വരുന്നത്. അപ്പോൾ ബാക്കി മാനിഫെസ്റ്റേഷൻസും delayed ആയിട്ട് ഇനിയും വരാം. ഇപ്പോൾ ആശയേ ഉള്ളൂ, രണ്ടാഴ്ച കഴിയുമ്പോൾ പേഷ്യന്റ് റീനൽ ഫെയിലിയർ വരാം, പിന്നെ ഹെപ്പാറ്റിക് ഫെയിലിയർ വരാം, ചിലപ്പോൾ eosinophilia പിന്നെ വരാം. So all these can happen, not always together, it can happen in subsequent period. Okay, so the treatment should also be continued. That immunosuppression need to be continued. Isn't treatment of choices? Steroids, and it needs to be continued for a longer time. Other 2 to 3 months we keep on monitoring. Depending upon that, we continue. 2 to 3 months we need to continue. We usually start by prednisolone 1 mg per kg or start it. Depends, depending on the severity. If you are not able to put it really into dress in a criteria under scoring okay under, you can refer. Adil put cheyan pattillenkil we keep it as mini dress pole oru sadhanam, because it is very severe. We cannot rule out dress. In that case, we can keep it as mini dress and start on systemic steroids. Okay, so these are the thing. So take home message. I cannot complete dermatology in 1.5 hour session. Just wanted to sensitize you. Maybe as per Sir said, SGSTN is important to you for exams and also SSS. I think that's the things which are important. But what I wanted to convey is, please give more care to the drug related things, like polypharmacy can be avoided, and also keep a note of when did you start. And most of the time another issue we face is bystander will not be there. So patient cannot say when the rash started. So it is good that you observe the patient daily. If on already a culprit or notorious drug aanengi, you have to write when the rash started. അത് വെച്ചിട്ടാണ് ഞങ്ങൾ ഡ്രഗിനെ കണ്ടുപിടിക്കുന്നത്. മനസ്സിലായോ? ഞങ്ങൾ ഡ്രഗ് you can write it. അല്ല, most of the time what we face is rash എന്നാ തുടങ്ങിയെന്നുള്ളത് നോട്ടീസ് ചെയ്യുന്ന ലേറ്റ് ആയിരിക്കാം, അല്ലെങ്കിൽ നോട്ട് ചെയ്തത് ഡേറ്റ് കാണത്തില്ല. അപ്പം നമ്മൾ ഡു യു നോ ഹൗ വി ഫൈൻഡ് ഔട്ട് വിച്ച് ഡ്രഗ് ഇറ്റ് ഇസ്? ഒരു 25 ഡ്രഗ് കാണും. അല്ലല്ല, അതാണ് പ്രശ്നം. നിങ്ങൾ വിചാരിക്കുന്ന ലാസ്റ്റ് തുടങ്ങുന്ന ഡ്രഗാണ്. അങ്ങനെയല്ല നമ്മൾ കണ്ടുപിടിക്കുന്നത്. നമ്മൾ ആ റെക്കോർഡ് മുഴുവൻ നോക്കിയിട്ട് സിംറ്റം തുടങ്ങിയതും ഈ ടൈപ്പ് ഓഫ് റാഷും നോക്കും. ടൈപ്പ് ഓഫ് റാഷും സിംറ്റവും തുടങ്ങിയ ഡ്രഗും തമ്മിൽ ലേറ്റൻ പീരീഡ് മാച്ച് ആവുന്നതാണ് നമ്മൾ പറയുന്നത്. പാർട്ടിക്കേരി ആണെങ്കിൽ അന്നോ അതിൻ്റെ തലേദിവസമോ അവേഴ്സ് മുമ്പ് തുടങ്ങിയതായിരിക്കും പറയുന്നത്. ഡ്രസ് ആണെങ്കിൽ ഒരു 4 to 5 weeks മുമ്പ് തുടങ്ങിയതായിരിക്കും പറയുന്നത്. TN ആണെങ്കിൽ ഇതിൻ്റെ കുറച്ചും കൂടെ ഒരു 1 week 2 weeksലുള്ളതായിരിക്കും പറയുന്നത്. AGP, there are more types of drug reactions which I have not mentioned here. So all those things, even there is something called fixed drug eruption. I don't know whether you know. Fixed drug eruption happens within 30 minutes. 30 minutes to or 8 hours. So we find the drug based on the type of rash or the type of the drug reaction and the latent period between the rash and the drug. മനസ്സിലായോ? അപ്പോൾ അത് ഭയങ്കര ഇമ്പോർട്ടൻ്റ് ആണ്. ആ ഡാറ്റ കിട്ടാൻ ഞങ്ങൾ വെള്ളം കുടിക്കാറുണ്ട്. That is more important. So keep document and in discharge summary. When you fill the discharge summary, sometimes people will come after discharge with a rash. അപ്പോൾ ഒരു ഫെനിറ്റോയിൻ തുടങ്ങിയ ഡേറ്റ് അറിയാൻ പറ്റത്തില്ല, അല്ലെങ്കിൽ ആൻറ്റിബയോട്ടിക്സ് ഗിവൺ എന്നായിരിക്കും കോസ് ഇൻ ദ ഹോസ്പിറ്റൽ. ദാറ്റ് യു റൈറ്റ്, നോ? അത് you should write. Alla, who writes? Alla, whoever writes. That is your responsibility. Ultimately, it is your responsibility. Alla, whatever we send when we see the summary, no, course in the hospital started on IV antibiotics, IV PPIs. That is very important for us to know. Finally, we send the patient back with a chit written. Please specify the drug, the time, the duration given, and date വെച്ച് ഡീറ്റെയിൽഡ് റിപ്പോർട്ട് ചോദിക്കാറുണ്ട്. ബിക്കോസ് ദാറ്റ് വി നീഡ് ടു നോ. അല്ലെങ്കിൽ പിന്നെ ഞങ്ങൾക്ക് വലിയ ടെൻഷൻ ഒന്നും എടുക്കണ്ട, സ്റ്റോപ്പ് ഓൾ ദ ഡ്രഗ്സ് സ്റ്റാർട്ടഡ് പ്രയർ ടു എന്നങ്ങ് എഴുതിയാൽ മതി. പക്ഷേ ശരിക്കും പേഷ്യൻ്റ് വെള്ളം കുടിക്കും. ബിക്കോസ് വെൻ ദേ ഹാവ് അറൌണ്ട് 10 or 12 ഡ്രഗ്സ് ആൻഡ് വി റൈറ്റ് സ്റ്റോപ്പ് എവറിത്തിങ്, എസ്പെഷ്യലി ആൻറ്റിബയോട്ടിക്സ്, ദേ വിൽ ഹാവ് ട്രബിൾ. ആൻഡ് ഓൾസോ ആൻറ്റി എപ്പിലെപ്റ്റിക്. ഞാൻ ഈ പറഞ്ഞ പ്രശ്നമുണ്ട്. ഫെനിറ്റോൻ എഴുതിയാൽ ഞങ്ങളൊരു 4 എണ്ണം കൂട്ടത്തിൽ എഴുതും. അപ്പോൾ അതിൻ്റെ കൂട്ടത്തിലൊരു ലെവിട്രസിറ്റാം കൂടെ ഉണ്ടെങ്കിൽ പെട്ടു. ബിക്കോസ് ദ ഡ്രഗ് വി ക്യാൻ ഗീവ് ഇസ് ലെവിട്രസിറ്റാം. ഇതെല്ലാം കൂടെ ഒരുമിച്ച് തുടങ്ങിയിട്ട് കണ്ടുപിടിക്കാൻ പറ്റിയില്ലെങ്കിൽ ദറ്റ് അഗെയിൻ ക്രിയേറ്റ്സ് പ്രോബ്ലം. സോ പ്ലീസ് മേക്ക് ഷുവർ ദറ്റ് യു മെയിൻറ്റെയിൻ ദ ഡോക്യുമെൻറ്റേഷൻ റെക്കോർഡ്സ് പ്രോപ്പർലി. ദറ്റ് ഇസ് ഇമ്പോർട്ടൻറ്റ് ഫോർ മെഡിക്കോ ലീഗൽ പോയിന്റ് ഓഫ് വ്യൂ ആസ് വെൽ. ഓക്കെ, അറിയാതെ നമ്മളൊരു പാൻറ്റോപ്രസോൾ എടുത്ത് എഴുതിയാലും there are issues. We have seen TN which is not resolving. When we check, there will be an azole later on added for oral candidiasis. TN ആയിരിക്കും, പാൻറ്റോപ്രസോളിനായിരിക്കും TN. അവോയ്ഡ് ഓൾ ഡ്രഗ്സ് ഇൻക്ലൂഡിങ് all chemically related drugs എഴുതി കാണും. കുറച്ച് ദിവസം കഴിയുമ്പോൾ you see that the patient has candidiasis, you add a fluconazole and the rash worsens. That can happen. Even candid mouth pain കൊടുത്തിട്ട് rash worsen ചെയ്ത സിനേറിയോ ഞങ്ങൾ കണ്ടിട്ടുണ്ട്. When we stopped it resolved. ഇതൊന്നും നോട്ട് എന്താ പറയുക, നമുക്കത് ഉറപ്പിക്കാൻ പറ്റില്ല. ചുമ്മാ റീചലഞ്ച് ഡീചലഞ്ച് വെച്ചിട്ട് we can just assume. അത്രേ ഉള്ളൂ. So make sure your documentation is very, very good. Find out the cause and treat. And also, please make sure that skincare is given adequately. You can take help of the dermatologist to know about the specific skincare that is needed for that patient. For what is required and good for one patient may not be good for the next patient. For what is for skincare for pemphigus does not hold good for pustular psoriasis. So I cannot actually make a comment on that here. So even if the dermatologist writes saline compresses, just ask the dermatologist, how do you practically give saline compresses? It may not be what you think. അത് മാത്രം പറഞ്ഞ് നമുക്ക് നിർത്താം. ആർക്കെങ്കിലും അറിയോ how to give saline compresses? I'm sure no. That is one of the best treatment option that we give for oozy lesions, crusted lesions, and it does wonders. The next day the patient will have a very clean looking wound. ആർക്കെങ്കിലും അറിയോ? ഇല്ല. Have you seen dermatologist writing? ഗോസ് വെക്കരുത് എന്നുള്ളതാണ് ആദ്യത്തെ പോയിന്റ്. ഇതും കൂടെ പറഞ്ഞ് നിർത്തിക്കോളാവേ. ആർക്കെങ്കിലും എന്തെങ്കിലും പറയാനുണ്ടോ? അല്ലെങ്കിൽ ജസ്റ്റ് ടെൽ ആൻഡ് സ്റ്റോപ്പ്. ഓക്കെ, സോ സലൈൻ എന്ന് പറയുമ്പോഴത്തേക്കും what we mean is actually normal saline. Okay, because we want something isotonic. Hypertonic ആയാലും പ്രശ്നമാണ്, ഹൈപ്പോട്ടോണിക് ആയാലും പ്രശ്നമാണ്. We want the അത് പിന്നെ പറയാം. ഓക്കെ, സോ ഹൗ ടു മേക്ക് ഐസോട്ടോണിക് സലൈൻ? യു ഹാവ് ICUലുണ്ട്, NS എടുക്കാം. അല്ലെങ്കിൽ അങ്ങനെ ഇല്ലാത്തൊരു സെറ്റപ്പ് ആണെങ്കിൽ യു ക്യാൻ ആസ്ക് ദം ടു പ്രിപ്പയർ. വി ആസ്ക് ദം ടു പ്രിപ്പയർ. ഓക്കെ, ഇഫ് യു വോണ്ട് ടു പ്രിപ്പയർ യു ക്യാൻ ടേക്ക് ഇറ്റ് ലൈക്ക് 1 liter 1 gram കോമൺ സോൾട്ട്. അത് 1 ലിറ്ററിൻ്റെ മറ്റേ ഡിസ്ലറിയുടെ കുപ്പിയിൽ പച്ചവെള്ളം എടുത്തിട്ട് 1 gram, അതായത് 2 ടീസ്പൂൺ കോമൺ സോൾട്ട് ലെവൽ ടീസ്പൂൺ ഇടാനാണ് പറയുന്നത്. ഓക്കെ, ഇറ്റ് ഷുഡ് ബി പച്ചവെള്ളം. നോർമൽ സലൈൻ ആണെങ്കിൽ കുഴപ്പമില്ല, ചൂടാകരുത്. വൈ? പൊള്ളുന്നതല്ല. സാധാരണ നമ്മൾ എത്ര പബ്ലിക്കിനോട് പറഞ്ഞാലും അവർ ചൂടുവെള്ളം എടുത്തേ ചെയ്യുള്ളൂ. ചൂടുവെള്ളം മീൻസ് lukewarm water. Why not? What are the actions we want here actually? What are the concerns we have? One is crusting, another is oozing, then infection. ഇതൊക്കെയാണ് നമുക്ക് മാനേജ് ചെയ്യേണ്ടത്. പിന്നെ എഡീമ. ഓക്കെ, അപ്പം ചൂടായ എന്ത് പറ്റും? ഊസിങ് എങ്ങനെയാണ് വരുന്നത്? വാസോഡൈലറ്റേഷൻ. വെരി നൈസ്. അപ്പോൾ വാസോഡൈലറ്റേഷൻ ആണ് ഇവിടുത്തെ പ്രശ്നം. നമ്മൾ ചൂട് വെച്ചാൽ എന്ത് പറ്റും? വീണ്ടും വാസോഡൈലറ്റേഷൻ. സോ വി വോണ്ട് ആക്ച്വലി വാസോ കൺസ്ട്രിക്ഷൻ. പക്ഷേ തണുപ്പ് വെച്ചാൽ ഹൈപ്പോതെർമിയ വരും. ഈവൻ സംടൈംസ് വി ഗിവ് കോൾഡ് കംപ്രസസ്. പക്ഷെ ഇവിടെ അത് വേണ്ട. പക്ഷേ you can give normal water compresses. So take a normal saline, normal temperature. Don't use gauze, don't use cotton. Use a cotton cloth which is thickly woven. അതായത് നമ്മുടെ ബെഡ്ഷീറ്റ്, കർച്ചീഫ്, മുണ്ടാണ് ഏറ്റവും ബെസ്റ്റ്. കോട്ടൺ. അത് പേഷ്യൻറ്റോട് വാങ്ങിക്കാൻ പറയാനേ പറ്റുള്ളൂ, വേറെ വഴിയൊന്നുമില്ല. നിങ്ങൾ ഗോസ് വെച്ച് ചെയ്യുന്ന കണ്ടിട്ടുള്ളതുകൊണ്ടാണ് ഞാൻ വീണ്ടും പറയുന്നത്. ഇറ്റ് ക്യാൻ ബി വാഷ്ഡ് ആൻഡ് ഓൾ. സ്റ്റെറൈൽ ആക്കണമെങ്കിൽ നിങ്ങൾക്ക് എങ്ങനെയെങ്കിലും ആക്കാം, സ്റ്റീം ചെയ്യാം. പക്ഷെ അതിൽ സ്റ്റെറൈൽ വലിയ കാര്യം വരത്തില്ല, ബിക്കോസ് ഇത് ഓൾറെഡി ഇൻഫെക്റ്റഡ് ആൻഡ് യൂസിങ് ആണല്ലോ. സ്റ്റെറിലിറ്റിക്ക് വലിയ റോൾ അവിടെ ഇല്ല ആക്ച്വലി സ്പീക്കിംഗ്. ഓക്കെ. ആൻഡ് പുതിയ തുണിയാണെ കഴുകിയിട്ടെടുക്കണം, അല്ലെങ്കിൽ അത് സ്റ്റിഫായിട്ടിരിക്കും. എന്നിട്ട് അതൊരു fold into 4 or 3 folds, so that the area finally achieved will be covering the skin condition. Okay, and put it in the saline. Just squeeze it with one hand. അത്രയും പോയാൽ മതി. അതിൽ കൂടുതൽ വെള്ളം പോരുത്, കുറവായി പോരുത്. Put it on the lesion for ഒരു 3 minutes. വാച്ച് നോക്കി തന്നെ 3 minutes വെക്കുക, എടുക്കുക, വീണ്ടും വെക്കുക, സലൈനിൽ മുക്കി സ്ക്വീസ് ചെയ്ത് വെക്കുക. You do it 10 times, around 30 minutes. Do it twice or thrice daily. You will see wonders. Next day, ചിലപ്പോൾ അന്ന് തന്നെ വൈകുന്നേരം ആകുമ്പോഴേക്കും oozy will subside, edema will subside, crusting പോവും, ഇൻഫെക്റ്റഡ് മെറ്റീരിയൽ ഉണ്ടെങ്കിൽ അതും പോവും. അത് പോകുമെന്ന് വെച്ച് കഴിഞ്ഞാൽ മെക്കാനിക്കലി വളരെ സട്ടിലായിട്ട് പോവും. വലിച്ചിളക്കുമ്പോൾ ബ്ലീഡ് ചെയ്യില്ലേ നോർമലി, അത് സംഭവിക്കാതെ സട്ടിലായിട്ട് ഇറ്റ് വിൽ ഗോ ഓഫ്. ആൻഡ് യുവർ ആൻറ്റിബയോട്ടിക്സ് വാട്ട് എവർ യു ആർ അപ്ലൈയിങ് വിൽ പെനിട്രേറ്റ് ബെറ്റർ. ഓക്കെ. Then second thing I want to tell is, don't try to use more of creams. Creams and ointments are two different things. Ointments are oil based, creams are water based. So whenever you apply ointments, it will create an occlusion, create some sort of a greasy ഇത് വരും. അപ്പം സീറസ് എക്സുഡേറ്റോ അല്ലെങ്കിൽ ഇൻഫെക്റ്റഡോ ആണെങ്കിൽ again it will cause occlusion and may cause harm to it. അതേസമയം cream ആണെങ്കിൽ it can exudate, the exudate can go through the cream. So always prescribe creams. Okay. പിന്നെ ഒരു കണ്ടീഷൻ വിച്ച് ഐ ഹാവ് സീൻ യു ആർ ഓൾവേസ് പാനിക്കിങ്, ബിനൈൻ കണ്ടീഷൻ ഇസ് മിലിയേറിയ. നിങ്ങൾ എപ്പോഴും നിങ്ങൾക്ക് കൺസൾട്ടേഷൻ വിടുന്നത് ഓടി വാ ഇപ്പം എന്താ പറ്റും എന്ന് പറഞ്ഞിട്ട് കൺസൾട്ടേഷൻ വിടുമ്പോൾ നമ്മുടെ PG OP ഓടി ഇറങ്ങി ചെല്ലുമ്പോൾ കാണുന്ന മിലിയേറിയ ആയിരിക്കും. മിലിയേറിയ എങ്ങനെയാണ് പ്രസന്റ് ചെയ്യുന്നത്? സ്മോൾ ചുവന്ന ചൂടുകുരു. യു നോ അബൌട്ട് ചൂടുകുരു. യൂഷ്വലി ബാക്കിൽ, ബെഡിനാണ് ബാക്കിലായിരിക്കും, സ്വെഡക്സ് ഒക്ലൂഡഡ് ആവുന്ന സ്ഥലങ്ങളിലായിരിക്കും. അല്ലാതെ ഒരു തരത്തിലൊരു മിലിയേറിയ വരാം, മിലിയേറിയ ക്രിസ്റ്റലീന. ദാറ്റ് വിൽ ജസ്റ്റ് ലുക്ക് ലൈക്ക് ഒരു പേളി ഡോട്ട്സ് ആയിട്ട് പ്രസന്റ് ചെയ്യും, ക്രിസ്റ്റൽസ് പോലെ. ദാറ്റ് ക്രിയേറ്റ്സ് കൺഫ്യൂഷൻ ഇൻ യു. അത് പെട്ടെന്ന് വെസിക്കിളാണോ വെരിസെല്ലയാണോ ഇങ്ങനെയൊക്കെയാണ് കൺസൾട്ടേഷൻ വരുന്നത്. അത് യു ക്യാൻ ഗൂഗിൾ ദ ഇമേജസ് ആൻഡ് സി. അത് ഇതിൽ വരാത്തതുകൊണ്ട് ഞാൻ എഴുതിയില്ല. മിലിയേറിയ ക്രിസ്റ്റലീന. ഇറ്റ് വിൽ യൂഷ്വലി ഹാപ്പൻ ഇൻ ക്രോപ്സ്. കുറച്ച് ദിവസം വെറുതെ വെള്ളമൊക്കെ തൊട്ട് തുടച്ച് കഴിഞ്ഞാൽ അങ്ങ് പോകും, പിന്നെ അടുത്ത ക്രോപ്പ് വരും. യൂഷ്വലി അസോസിയേറ്റഡ് വിത്ത് ഫീവർ ആയിരിക്കും. ഫിബ്രൈൽ ഇൽനെസ് കഴിയുമ്പോൾ സ്വെഡക്സ് ഒക്ലൂഡ് ആയിട്ട് വരുന്നത്. ഓക്കെ. സോ ദാറ്റ് ഇസ് അനദർ കണ്ടീഷൻ വിച്ച് ഇസ് ബിനൈൻ. യു ക്യാൻ ഇറ്റ്സെൽഫ്, പക്ഷേ ഡോണ്ട് അപ്ലൈ എനിത്തിങ് ഓവർ ദാറ്റ്. Again, what we see is you apply calamine over it. You are creating more of sweat duct occlusion. So അങ്ങനെ ഒരു കണ്ടീഷൻ കണ്ടാൽ യു അപ്ലൈ സം കോൾഡ് സ്പഞ്ചസ്. ഇതേപോലെ തന്നെ കോട്ടൺ തുണിയിൽ വെറുതെ വെള്ളത്തിൽ കംപ്രസസ് കൊടുക്കാം. So that sweat duct obstruction is gone. That will peel off. Again, another crop will come if this continues. We continue doing that. Okay, fine. So that is so I conclude. Any doubts you have or anything else to be clarified? Anything else? No more you wanted me to talk about? Ningada cater ചെയ്തോ? I don't know. This is the first time I am dealing with this topic because we don't need to address such a gathering. Usually it is, but I felt this is an opportunity to tell whatever frustrations I had also. Thank you. Sir. IV iron. So infusion reactions alle. Infusion reactions can occur with many drugs. Yeah. That is not a very severe issue actually. We cannot take adverse drug reactions can be benign or severe. അല്ല സിവിയർ ആണെന്ന് ഞാൻ ഈ പറഞ്ഞ SJSും ഡ്രസ്സും അങ്ങനത്തെ സാധനങ്ങളൊക്കെ ഇതൊക്കെ ആക്ച്വലി മൈൽഡർ വേരിയന്റിൽ പെടുത്താം. സോ ഇറ്റ് ക്യാൻ ബി ആക്ച്വലി ബിനൈൻ ആയിട്ട് കൂട്ടാം. Actually, we don't actually deal with bed sores because അത് കൂടുതലും സർജൻസും പ്ലാസ്റ്റിക് സർജൻസുമാണ് ഡീൽ ചെയ്യുന്നത്. What we usually do is ഈ പറഞ്ഞ ചേഞ്ച് ഇൻ പൊസിഷൻ പറയാറുണ്ട്, എയർ ബെഡ്സ് പറയാറുണ്ട്. Once it is infected and necrosed ആയിക്കഴിഞ്ഞാൽ we'll have to go for debridement and then go for a lot of dressing. Surgeons may know better. Lot of dressings available now which can help you. പക്ഷേ actually I'm not the best person to tell more on that. അതൊരു ക്വസ്റ്റ്യൻ ആണ്. ആക്ച്വലി ഐ ഡിഡ്ന്റ് മെൻഷൻ അബൌട്ട് ആൻജിയോഡീമ, അനാഫിലാക്സിസ്, സർട്ടിക്കേരിയ. അത് മനഃപൂർവ്വം വിട്ടതാ, നിങ്ങൾക്ക് അറിയാലോ എന്ന് വിചാരിച്ചിട്ട്. കാര്യം അതിന്റെ മാനേജ്മെന്റ് പാർട്ട് യു നോ വെരി വെൽ. ഡയഗ്നോസിസ് ഇസ് നോട്ട് വെരി റോക്കറ്റ് സയൻസ് ഒന്നും അല്ല. ഡ്രസ്സും DHS ഒക്കെ നിങ്ങൾക്ക് അറിയില്ല എന്ന് എനിക്കറിയാം. ആൻജിയോഡീമ, സർട്ടിക്കേരിയ യു ക്യാൻ ഡയഗ്നോസ്, ഐ നോ. ദാറ്റ്സ് വൈ ഐ സ്കിപ്ഡ് ഇറ്റ്. Madam's question is, a patient with anaphylaxis to one drug developing, when they give Avil, again they develop rash. Adale scenario. He gives history of allergy to Avil. അത് ഈ പേഷ്യന്റ് ഹിസ്റ്ററി പറയുന്ന പലപ്പോഴും ഭയങ്കര ട്രിക്കിയാണ്. അത് വൺസ് ആൻ അക്യൂട്ട് അർട്ടിക്കേരിയ ഡെവലപ്സ് ഓർ ഈവൻ റിക്കറന്റ് ക്രോണിക് അർട്ടിക്കേരിയ ഉള്ള ആൾക്ക് റിക്കറന്റ് അർട്ടിക്കേരിയ ഡെവലപ്പ് ചെയ്ത് കഴിഞ്ഞാൽ ദാറ്റ് എപ്പിസോഡ് മേ കണ്ടിന്യൂ ഫോർ സം ടൈം. ഇറ്റ് ടേക്ക് ഈവൻ വീക്സ് ടു സബ്സൈഡ്. അതിൻ്റെ ഇടയിൽ നമ്മൾ കൊടുക്കുന്ന ഓരോ ഡ്രഗിനും നോർമൽ നാച്ചുറൽ കോസിൽ റാഷ് വരുമ്പം ദേ മേ അട്രിബ്യൂട്ട്. വി നോ എ ലോട്ട് ഓഫ് പേഷ്യൻസ് വിത്ത് ക്രോണിക് അർട്ടിക്കേരിയ. അവർ പറയും എനിക്ക് അവിൽ അലർജിയാണ്, എനിക്ക് അട്രാക്സ് അലർജിയാണ്, എനിക്ക് മറ്റേ. അവസാനം ദേ ആക്ച്വലി ബൈ എക്സ്പീരിയൻസ് ദേ ലേൺ ഓൾ ദ നെയിംസ്. പിന്നെ ആ പേരെല്ലാം പഠിച്ചു വെച്ചാൽ അത് എപ്പോൾ കഴിച്ചാലും അലർജിയാണെന്ന് ഇവർ പറഞ്ഞുകൊണ്ടിരിക്കും. അപ്പം വൺ തിങ് യു ക്യാൻ ഡു ഇസ് യു അഡ്മിറ്റ് ആൻഡ് അണ്ടർ യുവർ സൂപ്പർവിഷൻ ട്രൈ ടു ഗീവ്. ഓക്കെ, പക്ഷേ ആരെങ്കിലും ഡോക്യുമെന്റ് ചെയ്തിട്ടുണ്ടെങ്കിൽ ബെറ്റർ നോട്ട് ടു ട്രൈ. സച്ച് പേഷ്യൻസ് വെയർ വി കനോട്ട് ഗീവ് എനി ആൻറ്റിഹിസ്റ്റമിൻ, അനാഫ്ലാക്സ് ഒന്നും ഉള്ള കാര്യമില്ല ഞാൻ പറയുന്നത്. ക്രോണിക് അർട്ടിക്കേരിയ പേഷ്യൻ യൂഷ്വലി കം, അവർക്കൊന്നും കൊടുക്കാൻ പറ്റത്തില്ല, ഒന്നും എടുക്കാൻ പറ്റത്തില്ല, അവർ കഴിച്ച പ്രശ്നം, അവർ കഴിച്ച പ്രശ്നം. ശരിക്കും കൺവിൻസ്ഡ് ആണെങ്കിൽ വി ട്രൈ ടു അവോയ്ഡ് ദാറ്റ് കെമിക്കൽ ഗ്രൂപ്പ്. ഫോർ എക്സാമ്പിൾ, അവിലാണെങ്കിൽ ഇറ്റ് ഇസ് വാട്ട് ഇസ് അവിൽ? ഫെനിറമിൻ മാലീറ്റ്. CPM ഇസ് ക്ലോർഫെനിറമിൻ മാലീറ്റ്. അപ്പം CPM അവിലും ഒരേ ഗ്രൂപ്പിൽ വരും. വേണമെങ്കിൽ മറ്റ് അമീൻസും അതുപോലെ വരുന്ന എല്ലാം അവോയ്ഡ് ചെയ്യാം. സിമിലർലി സിട്രസിന്റെ ഗ്രൂപ്പിൽ തന്നെയാണ് ഹൈഡ്രോക്സിസിൻ, അട്രാക്സ് ഒക്കെ വരുന്നത്. അപ്പോൾ കൺവിൻസ്ഡ് ആണ്, യു ട്രൈ ടു അവോയ്ഡ് ദാറ്റ് കെമിക്കൽ ഗ്രൂപ്പ് ആൻഡ് ട്രൈ വിത്ത് അതേഴ്സ്. ഫസ്റ്റ് തിങ് ഇസ് യു ഹാവ് ടു ഗെറ്റ് കൺവിൻസ്ഡ്. പിന്നെ ഓൾറെഡി ഒരാൾ റെക്കോർഡ് ചെയ്ത് വെച്ചിരിക്കുന്നതിൻ്റെ മുകളിൽ നമ്മൾ ട്രൈ ചെയ്ത് മെഡിക്കൽ ലീഗൽ ഇഷ്യൂ ഉണ്ടാക്കാതിരിക്കുന്നതാണ് നമുക്ക് സേഫ്. ദാറ്റ് യു യൂസ് യുവർ ഡിസ്ക്രിപ്ഷണറി പവർ ടു decide on that. But one thing is for sure, one urticaria episode when it starts, it will continue for some time. If you want to say it is not due to the drug, due to the natural course of the disease എന്ന് പറയണമെങ്കിൽ അത് ആ സമയത്തല്ലാത്ത അർട്ടിക്കേരിയ ഇല്ലാത്തൊരു സമയത്ത് റീചലഞ്ച് ചെയ്ത് നോക്കണം, എന്നാൽ മാത്രമേ പറയാൻ പറ്റുള്ളൂ. പിന്നെ ഡ്രഗോളജി ടെസ്റ്റിംഗ് ഹാസ് നോ മച്ച് റൂൾ. ഇരിക്കുന്ന അനസ്തീഷ്യക്കാരൻ എന്നോട് സമ്മതിക്കത്തില്ലെന്ന് എനിക്കറിയാം. ഡ്രഗോളജി ടെസ്റ്റിങ്ങും ക്ലിനിക്കൽ കോറിലേഷനും ഭയങ്കര പ്രശ്നമാണ്. പേഷ്യൻറ്റ് വിത്ത് നോൺ അലർജി ദേ വിൽ ഗീവ് നെഗറ്റീവ് റിപ്പോർട്ട്. വിത്തൗട്ട് ഒരു കുഴപ്പമില്ലാത്ത നമ്മൾ സ്ഥിരമായി കൊടുക്കുന്ന സാധനത്തിന് ദേ വിൽ ഗീവ് എ പോസിറ്റീവ് റിപ്പോർട്ട്. ദർ ഇസ് എ ലോട്ട് ഓഫ് ഫാലസി അസോസിയേറ്റഡ് വിത്ത് ബോത്ത് ഡ്രഗോളജി ടെസ്റ്റിംഗ് ആസ് വെൽ as food allergy testing. Last day I had a patient who was a staff nurse. She was literally crying in front of me telling, I have got a food allergy testing report. അതിലെല്ലാം ഉണ്ട്, ചോറ് വരെ ഉണ്ട്. അവർക്ക് ആക്ച്വലി ചോറൊന്നും കഴിച്ചാൽ കുഴപ്പമില്ല, എല്ലാം ഉണ്ട്. ആൻഡ് ഹെർ ഫാമിലി ഇസ് നോട്ട് എന്താ ഒന്നും കഴിക്കാൻ സമ്മതിക്കത്തില്ല. കൈൻഡ്ലി ഹെൽപ്പ് മീ, എന്ത് ചെയ്യാം. ഞാൻ ഒളിച്ചൊക്കെ കഴിക്കും, പക്ഷെ എനിക്ക് ഐ വോണ്ട് ടു നോ ദാറ്റ് ഇറ്റ്സ് നോട്ട് ചോറ്. ഷീ വോണ്ട്സ് ടു ഈറ്റ് ചോറ് ആൻഡ് മീൻ. സോ ഫൈനലി ഐ അഡ്വൈസ്ഡ് ഹർ അഡ്മിഷൻ സോ ദാറ്റ് വി ക്യാൻ ട്രൈ ഇറ്റ് under supervision. That is the only thing I can do, because drugology testing is always having a lot of false positive and false negatives. So we can wind up. So thank you.
So without wasting much time, thank you very much for this talk. Thank you.